Welcome, everyone. I'm Peggy McGuire, the president of the Cambia Health Foundation and co-chair of this roundtable, along with Dr. James Tulsky. On behalf of Dr. Tulsky, the roundtable staff, and myself, it is a pleasure to welcome you to today's webinar. Thank you so much for being with us today. This roundtable fosters dialogue about improving care for people with serious illness. We focus on 5 priority areas: the delivery of person-focused and family-oriented care, communication and advanced care planning, professional education and development, policy and payment systems, and public education and engagement. The roundtable convenes a diverse group of public and private stakeholders to explore issues that impact people with serious illness. We sponsor public workshops to explore critical topics, like the one we're here to discuss today. There's more information on the roundtable's website, and you see the link on your screen. So if you're curious about the roundtable, please go to the website for more information. As we get started today, I want to say a hearty thank you to our roundtable sponsors. We literally could not do this work without you, so thank you very much for making this work possible. As I mentioned, the materials for today will also be included on the website for the roundtable. The link is on your chat. The link is on your screen. There will be time at the end of each session for Q&A. So as we ask that you put the Q&A in the Q&A box, not the chat box, so that our facilitators will be able to see it. Finally, I'd like to thank our planning committee. You see their names here on the screen. It takes a lot of work to put a program like this together. I know that it's a labor of love for the people on our planning committee, and I just want to thank you all so much for your efforts, and also to thank the tremendous staff at the roundtable. You also see their names listed below. And now it's my great honor to introduce our planning committee co-chair for today's event, Bryn Bowman. Bryn.
Thank you, Peggy, for that introduction and for your leadership of the roundtable. And welcome, everybody. We are so glad that you could join us for today's event. This is the second of 3 webinars focused on how the pandemic has affected how we care for people with serious illness and their families. And I want to start today by grounding us in what do we mean when we say serious illness? Serious illness is a health condition that carries a high risk of mortality and that impacts a person's function or quality of life, or puts strain on their caregivers. And in the context of this workshop, we think of serious illness as inclusive of both patients with COVID and of other illnesses that people have been coping with throughout the pandemic, like cancer or dementia or COPD. Because palliative care professionals are specialists that focus on relief from the symptoms and stressors of a serious illness for patients and families, in our workshop, many of the voices and pandemic stories that you'll hear are from palliative care leaders. However, we know that, of course, patients with serious illness interact with a wide range of clinicians in a wide range of settings. And the roundtable really does think about improving care for people with serious illness through a 360-degree lens. And so including the work of palliative care specialists, but also reflecting the many, many other touch points between a patient and the health system. In our first webinar 2 weeks ago, we discussed the immediate impact on patients, on families, on health professionals, and healthcare organizations when the pandemic hit. And we also heard about the innovation that immediately began to happen across the country, driven by the goal of reducing suffering, preventing crises where possible, and inserting humanity and dignity into healthcare interactions despite the fear and the chaos of those early days of the pandemic. We also talked about health disparities for historically oppressed or underserved communities, and how, as one of our keynote speakers, Dr. Ebony Bulwar noted, the story of the pandemic is also a story about inequity. I will admit that our planning committee had difficulty deciding where to focus our second webinar because, as we all know, virtually every aspect of care delivery and of patients' experiences has been touched by the pandemic. But we decided today to focus on two particular domains because, put simply, they will never be the same after COVID. And that is the workforce that cares for people with serious illness and telehealth. We will hear from a group of thought leaders representing diverse perspectives on these issues in an effort to get our hands around what we've learned about the strains on our workforce and the way that who and what we're referring to when we think about the serious illness workforce has changed during COVID. In our second session today, we'll talk about how we can filter the lessons that we learned about telehealth during crisis and translate them to ongoing care delivery that leverages all that telehealth has to offer without putting care quality or equity at risk. These two topics, workforce and telehealth, are of course inextricably linked. We know that in many health systems across the country, for example, the scarce resource that is palliative care specialists were able to expand their capacity and be when and where they were needed during the pandemic because they have provided care via telehealth. We know that technology was used to connect families who couldn't be at the bedside of dying loved ones, and that the capacity to make those connections over an iPad helped to relieve some degree of the moral distress of a battered healthcare workforce. Our speakers today will help us think about how to put these lessons that we've learned into practice as we look towards the future of care for patients with serious illness. Before we dive in, I want to quickly remind everyone that the full bios for all of today's speakers and moderators can be found in the briefing book on the event webpage. And now it has been a real privilege to co-chair this workshop with Dr. Susan Wong. Susan is the national lead for palliative care at Kaiser Permanente and the Southern California chief of the Department of Geriatrics and Palliative Medicine and the medical director for life care planning and serious illness care. I will hand it over to Susan to lead our first session.
Thank you so much, Bryn, for that helpful overview. We will start the first session today with what we call a lived experience or perspective. And it is my pleasure to welcome Dr. Rodney Tucker as our speaker. He is professor of medicine, interim division director of gerontology, geriatrics, and palliative care, and the director of palliative and supportive care at UAB. Welcome.
Thank you, Susan, and thank you, Brian, and thank you to everyone in the planning, the roundtable that you've asked me to speak today. I certainly appreciate the honor, and a couple of years ago, I would have never thought that I would be speaking about my lived experience in COVID. But where I'd like to start, just a few brief comments, is to take just a moment to ask each of you, as we think about the challenge and the impact, and my title of a lived experience, is take a moment, just close your eyes, and think about the experience of those who this was a loss, and for those that we have lost during the COVID-19 pandemic so far. So if you don't mind, just take a moment, close your eyes, think about a few individuals that you may be familiar with that you've lost. So I can think of many early in the pandemic and in 2021 as well. So I want to talk about my lived experience just for a second. So the next slide outlines for you the way that I framed my experience. Beginning in 2020, in March of 2020, when we're doing right, shut down, remote work, hygiene, mask, distance, empathy strong. The healthcare providers are healthcare heroes. We moved through July of 2020 to December, continued to do everything right, ready for 2021. Vaccines arrived 2021, along with the worst surge that we had, particularly here in our state of Alabama. Continued to do everything right, fatigued, but intact. Then we move into April, May 2021, guard slightly down, still doing everything mostly right, frustrated with vaccination rates. And then June of 2021, what hits me personally is, despite vaccination, despite doing most everything right, COVID positive with the Delta variant, spouse with bilateral pneumonia, and So the loss that I had, the loss that I began to feel was a loss of empathy. Empathy tested like really never before. So the next slide shows what I think is one of the most intense or comprehensive looks adapted from Zerton and Myers of the trajectory, or I like to sort of think about this as the emotional trajectory that I was going through with COVID. And the anniversary reactions, which you see in the bottom right, was about where I guess I was when the COVID variant hit our household. And so I think this is a very insightful, diagrammatic sort of part of our journey. And where we are now, as we look at reconstruction, we have to look backwards as well to see what we've been through. The next slide shows something that, as far as the challenges for the team, I don't have to go into any detail with this because we've all experienced this. This is the great nature of this series, to look at all of these different aspects, but the professional challenges for our team and then our personal challenges. And so when we look at these together, obviously this is a recipe for challenges to resiliency and burnout. And so as we as a team look to each other to see, well, how do we survive? How do we get through this when we have these challenges? And this is not a complete list entirely of the challenges of an impact, of COVID. And while we look toward the disruptive innovations that will enhance our healthcare system and bring issues to the forefront, such as disparities, et cetera, we still have to look back and say, this was a very tough hit to professional and personal resilience. So the next slide, really, we had to look at measures to reinforce resiliency and burnout. We were already thinking about this, and as a field, obviously, these considerations prior to COVID. So the pandemic particularly challenged us in ways, and we had multiple, thoughts and ideas over the last 18 months. How do we support? How do we design programs, particularly for our faculty, for our team, for our staff members, after losing one of our prized nurses, one of our wonderful colleagues on our palliative and comfort care unit. How do we get through all of this? And one of the things that we did as a team, and I think many institutions do, is measure well-being in some way that we have. So we continued to measure our well-being index, but most importantly, we continued to act upon our well-being index, because we knew that as a measure, while it may not be perfect, we wanted to track this and really measure what we could do to help our team. So understanding the trajectory of the response during this time was really key. And we realized, as I'm sure I don't have to reinforce to this audience, that this is much like a significant loss or a grief response. And finally, what we arrived at after trying many different both individual and team-based activities is that we had to encourage three simple things, and that was flexibility in terms of our schedule and our ability to help each other, the power of the debrief, which we've always believed and practiced in palliative care. And then I guess one of the most important things that we had to arrive at was to have grace in ourselves. And that's the way that I guess at the end of the day that I've begun to recharge myself and to look toward how I continue to have resilience. So the last slide is something that, or next to last slide, is something I only came across recently, and it's work of Rock and Associates about the concept of circling up. Some of you have probably seen this as Circle Up framework. And so we and our team have started these practices, and to basically debrief with each other, to check in, to be heard, to listen, and to ask each other these type of questions, because this seems to be something that universally we all appreciate and helps us to regain some of our energy, some of our resilience, and to know that we will be okay one step at a time, one debrief at a time, one conversation at a time, as we all strive to look to see what is our next normal. I say next normal, now normal, because I don't know what the new normal will be. I don't think any of us do. And so this is the power of Circle Up. And I think it's going to be one of the things that our team particularly will look forward to as we begin part of our reconstruction, as we talked about. So my last slide is a poem of remembrance. I have to give a shout out to the Good Listening Project. If some of you have heard of the Good Listening Project, as a board member of the American Academy this past year, our board members took part in a listening poet session at the end of 2020. And this was my poem, and this is how I'll end my lived experience today. With my poet listener, she developed after listening to me and just circling up in a way with someone outside of my immediate team. She wrote this poem for me. So, farewell 2020. You're coming to a close with contradiction, disruption, one-dimensionality, life-changing chaos, prolonged paradox, invigoration and frustration, gratefulness and fearfulness. 2020, you're coming to a close, and I still don't like yoga. I meditate to pop Latin dance music. I still hate podcasts, and I binge on Netflix. I show grace to myself in how I find resilience. There's no one way that works for everybody. I don't tell others how to find it. I don't want others telling me. 2020, you can't come to a close fast enough. You've left me not knowing how to feel or act. You've challenged the can-do side of me. You've got me questioning what I'll feel looking back. Will I be sad about what was taken away, or happy to have come through healthy? 2021, for now, I've one intention: simply stay well and sane. Again, I appreciate the opportunity to share a little lived experience from my perspective.
Thank you, Dr. Tucker, for sharing your powerful story in that poem. We look forward to having you join our panel discussion in a little bit. So now I'd like to introduce our next speaker around workforce challenges and innovations. Elaine Larson is the Anna C. Maxwell Professor of Research Emerita and Special Lecture, School of Nursing, and Professor Emerita of Epidemiology, Mailman School of Public Health at Columbia University, and Senior Scholar in Residence, New York Academy of Medicine. Welcome.
Thank you. I'm going to talk about the nursing workforce. I'll give you a little bit of background, and then I want to focus on a special and important group of seriously ill, those that are in long-term care and in receiving home care, and then end with some recommendations for enhancing and responding to the workforce challenges. Nursing is the nation's largest healthcare profession with more than 3.8 million registered nurses. That's 3 times as many nurses, registered nurses in the US as physicians. RN shortages are not new. They've been going on for years, up and down, and they are projected, even before the pandemic, projected to continue through 2030, most intense in the South and the West regions. On top of that, changing demographics, clearly the aging population, the higher prevalence of serious chronic illness, are increasing the demand for nursing, while at the same time, a considerable portion of the workforce is nearing retirement. Staffing shortages are increasing stress and job dissatisfaction, and the recent pandemic has exacerbated this problem. All of this is happening despite the fact that multiple studies have reported a significant correlation between inadequate nurse staffing and higher rates of adverse events, morbidity, and mortality. In the next slide, I'm giving you some results, summary of a survey of about 7,000 nurses across the country. It was reported, it was from 2019, prior to COVID. So even prior to COVID, 14% of nurses reported that in the previous year, they had been assaulted by a patient or family. 23% experienced verbal and nonverbal aggression from a person in authority. 31% experienced verbal and nonverbal aggression from a peer. 24% said staffing levels were not safe. And about a fourth also that were often assigned to higher loads than they felt were safe. 27% reported excessive fatigue affecting their quality of life. And 63% said that, that they experienced excessive workforce. So the next slide summarizes the impact of COVID on the nursing workforce. This is the same type of survey that was administered in the middle of the pandemic. I think it was about September, August, September of this year, of 2020. So of the 22% of nurses who indicated that they may leave their current positions, 60% said they were more likely to leave since the pandemic began. And they gave three major reasons: insufficient staffing, unsafe workloads, and emotional toll. The reported problems included accelerated retirements, again, regional variations and shortages, specialized skill gaps, which we saw highlighted, for example, with use of PPE, and the need for strategic workforce planning. Hence, as with the inequities in patient access and care, problems with the nursing workforce are longstanding and embedded in the system, but COVID has exacerbated and highlighted existing conditions. The next slide, I want to focus on the subgroup of seriously ill people who are receiving long-term care or home care. The majority of these individuals have serious advanced illness. A primary cause of morbidity and mortality in these individuals is infection, particularly with antimicrobial resistant organisms. I mention that because that's my particular area of interest. Nursing homes, in fact, serve as a major reservoir for transmission of infection and antibiotic resistance. 2/3 of residents receive at least one antibiotic every year. A large proportion of those are inappropriate use. About 2.6 million infections from nursing homes are reported annually to CMS. Probably that's an underestimate. About 4 million nursing home residents are transferred to hospitals each year. 40% of the transfers are due to infection, and 60% have infections on hospital admission. So in the next slide, I'm giving you one example of something that has been an effort through the ECHO program to help mitigate these problems. ECHO, you probably have heard of, a project funded by the Agency for Healthcare Research and Quality. It's a guided practice model that reduces health disparities in underserved and remote areas using telemonitoring. So it was ideal during the pandemic. It uses a hub and spoke knowledge sharing approach where expert teams lead virtual clinics. In the next slide, I'm going to just mention the program that the ECHO project called the COVID-19 Action Network, in which the New York Academy of Medicine participated along with other people and IHI, for example. This was launched in September of 2020. About 9,000 nursing homes participated across the country in weekly sessions and received a modest stipend for participating. The sessions, there were usually about 16 sessions, 16 weeks, weekly sessions. They included short lectures, case-based presentations, the development of quality improvement skills, and group discussion. The New York Academy of Medicine's Training Center recruited, planned, and convened weekly sessions for about 150 nursing homes in New York and Connecticut. In the next slide, I want to summarize some of the relevant findings related to the workforce. We have published these findings in a couple of papers that are already published and 2 that are in press. But just to summarize, the frontline caregivers, who are primarily certified nursing assistants, are often people of color and or first-generation immigrants without advanced degrees with very little formal training. They often received minimum wage and sometimes had several jobs to support their families, increasing the risk of cross-transmission between facilities, and reducing job satisfaction and staff retention. These, by the way, are from our qualitative interviews with a number of nursing homes in the greater metropolitan New York area. Inequities in care were obviously prevalent, and we know that. We've heard a lot about that. For example, Blacks were significantly less likely to receive vaccination. Outcome data were collected, often because it was mandated that be collected and reported, but rarely used. The staff didn't know about the outcome data, nor did some of the nursing directors of the units. So it was rarely used, really, for improving the quality of care, and it was rarely communicated to the frontline staff. For example, fewer than 40% of facilities reported using isolation precautions for infected patients. Now, this is not COVID, this is any kind of infection, MRSA, Clostridium difficile, et cetera. We also found that the organizational culture and leadership were highly correlated with patient safety and care practices and outcomes. And although improved training is significantly associated with fewer citations for infection control violations, staff responsible for infection control generally wore multiple hats, and most reported that they had received no formal training at all. So based on these things and other data sources as well, I want to summarize in the next slide 4 major recommendations for how we might respond to this and support the nursing workforce. First of all, and these are partly from nurses reporting themselves and from other research studies, make the workforce health and well-being part of the system. For example, provide equitable and adequate wages to the frontline direct care staff, provide recognition, appreciation, and economic rewards commensurate with value. And often what we found is that the recognition and the appreciation was just as important as the economic rewards to people, to the nursing staff, and provide resources for mental health and work breaks, and provide clear, transparent communication, particularly between administration and the frontline staff. The second recommendation, increase workforce flexibility, require less overtime, enhance client, staff, patient participation in decision-making and scheduling. If we have time during the question and answer period, I'd like to provide you with an example of a couple of things that I heard from my colleagues who were doing frontline work at the time and the kinds of work that they were expected to do and the hours. The third recommendation, reimagine delivery models and improve organizational climate, leveraging digital tools, which we've gotten pretty good at. It can always get better. Adapting care models based on patient and employee preferences, support leadership training programs and mentorship. And I want to focus on that because there have been several studies lately that show that there's a very high correlation between the leader and job satisfaction and job retention. And then building learning networks and coalitions across agencies and systems of care. This is going to require major change in the way, the structure of our acute and chronic care systems. And then strengthen talent pipelines and build skills for the future. Implement national training requirements for frontline staff based on core competency standards. Support reskilling when needed, and bolster recruitment pipeline for clinical roles. So these are some data sources on the next slide, and I look forward to the question and answer time. Thank you.
Thank you, Elaine. We look forward to that time with you as well. We really appreciate the opportunity. Next up is Liz Fowler, who is President and CEO of Bluegrass Care Navigators. Welcome.
Thank you, and you can go on to the next slide. So I included this just to give you some context of who we are and the perspective I'll be speaking from. We are a community-based organization headquartered in Lexington, Kentucky, and the state map at the bottom shows all of our counties, and the dark teal green is where we provide care. And the northern part of Kentucky, that is really a Cincinnati suburb, very suburban community. Central Kentucky is where Lexington is, so we have an urban area, as well as many farms, horse farms, as well as agricultural farms. And then Eastern Kentucky, where the tip is all the way through the south, is very rural Appalachia. Mountainous, distant, high levels of poverty. In fact, we have some of the counties with the highest poverty levels in the nation. And even some of our homes lack adequate electricity, clean water. And so it gives you context for where we're serving. Our patients are seriously ill. Many of them are hospice patients. We have a large hospice program, but we also provide home-based palliative care, home-based primary care, and a number of care models that include home coaching and other services to folks that are experiencing multiple chronic conditions. We have about 750 team members, so we aren't huge, but large enough to give you some context, and about 20,000 patients annually is who we touch. Next slide. So we had a crisis that was looming. The pandemic was declared, and it didn't come to Kentucky right away. So our workforce was watching, waiting. We heard of what was going on in New York, Oregon, other areas of the country. Some of our colleagues would share stories of where they had closed actually full hospice inpatient units or lost great amounts of their team to the pandemic and illness. And we were scared, and some panic was setting in. So what we did is we set up a communication that was very disciplined, very thoughtful, and we thought might be over communicating, but it really served us well. And one thing, for example, we did was a standardized daily email using the SBAR format that had the situation, the background, actions to take, recommendations that came out after 5:30 every day. And our team really appreciated that regular communication. And part of helping us to prepare also was looking at our workforce supply. How would we take care of patients if team members became ill or unavailable? And in that, we set what standards, what we do every day when we have adequate staffing, but then decided what is contingency, crisis, and then ultimately catastrophic staffing levels. Who would do what services would be provided to patients. And with that, we cross-trained everyone to do alternate jobs. So nurses that might be in administrative roles, they were trained how to go out and do visits. We took office workers and we trained them, for example, to be medical equipment technicians, to decontaminate the equipment and to be able to dispatch it and install it in patients' homes. So all of that cross-training and then communicating what it would look like. So when a team reached contingency level, they knew who was coming to help. Or when they reached crisis level, who was coming to help? How were patients going to be taken care of? Fortunately, we never reached catastrophic levels, but we were prepared for that if we needed it. Let's go on to the next slide. So what we realized, and as our previous speakers spoke to, is we had to give a whole lot of personal and professional support to our team. Over a period of 2 days when the pandemic was declared in Kentucky, we transitioned everyone to remote work, and schools were closed, services were unavailable, and we realized right away our team members were going to need a lot of flexibility. Fortunately, we provide care 24 hours a day, 7 days a week, and quite frankly, it makes us easy to provide care to individuals after hours. We don't need to work 8 to 5 only. You can work anytime. So we kind of got that mindset. You can work anytime. We just need to communicate that well. We also realized it needed to be very individualized, and that's where managers really had to lean into what their individual folks needed. You know, someone said, I have to get my kindergartner on a Zoom call at 10 o'clock. They can't do it by themselves. We knew they couldn't do meetings at 10 o'clock or be at a patient home at 10 o'clock. So we tried to really hone in on what individuals needed. And we also surveyed our team often to hone in on their needs. We didn't want to make assumptions. And I'll tell you one journey we went on when we heard kids were at home and people were struggling with teaching the kids. And we thought, well, let's just hire a tutoring service. And any of our team members could get on-demand tutoring. Well, when we surveyed team members, that wasn't their stress, the content. They needed desks. They needed laptops. And our offices were closed. We opened them up and we said, come pick up a desk. We had laptops we could refurbish and send home. So we quickly pivoted when we surveyed folks to lean into their needs. The other thing is our core values served us well. One of our core values is compassion, respect, and dignity. And we give that to our patients every day. And we leaned into that as what did we need to do for our team members to show them compassion, show them respect, show them dignity. And that served us very well also. Another example of something we did to really support our workforce, we hired business coaches for our managers. Not all of them took advantage of it, but we had one of our managers who honestly shared in a meeting. She was quite brave about it. She said, I go home every day and I cry. And we realized, yeah, this is a sad time. And going home and every day and crying can be normal. And these business coaches, we wanted them to help our managers normalize their feelings. That sadness, exasperation, fatigue were all normal. But how could we bolster them so they could continue to be their best professionally and personally? Next slide. So we did do the professional quality of life scale in February of 2021, and it really told us some startling things about our team. 70% reported feeling worn out by their work as a helper, and 64% reported feeling overwhelmed by their work assignments and that their work was never ending. So that, we knew something was going on and more needed to be done for our team, but this really was startling to us. We also at that time began to see a staggering increase in our healthcare claims. We're a self-insured plan. And we asked an analyst to dive in and tell us what they could about what they were seeing in the medical needs of our team. And we thought, well, it's this catch-up care that was occurring since people delayed care during the first part of the pandemic. And it wasn't. They were claims of $10,000 to $15,000 for short inpatient stays. They weren't catastrophic healthcare needs either. And we also, I put it on this slide, depression ranked 4th in our chronic conditions. And most of our claimants were also showing a diagnosis of depression. And it was kind of the chicken or the egg. Were they depressed, so they needed medical care, or were they have chronic conditions that cause depression? And we finally said, we don't need to know that. We need to know depression is there. ADHD also ranked really high. And just in the first quarter of 2021, our ER visits related to depression and ADHD cost us $46,000. So led us to lean in a little bit more. And we have spent this year, let's go on to the next slide, really focusing on the well-being of our team. We, right at the beginning of the pandemic, had hired a clinical psychologist to join our team to support patients. Well, we ended up asking her to do mindfulness moments for our team that anyone could call in at various times of the day. She offers these breaks. We also partnered with the Schwartz Center for Compassionate Healthcare, and we are now hosting Schwartz rounds. And for those of you that might not be familiar, they are rounds that create a safe place for our team members to work through their feelings and normalize and process their roles as being helpers for folks with serious illness. We began Code Lavenders and Code Lavender Response Team, and that was modeled after a Cleveland Clinic program where frontline clinicians, we offer debriefings for their stressful work-related incidents. And anyone can ask for for a code lavender. Even peers can request it for others or for their team. And we've actually moved from not only can frontline clinicians do we support them with code lavenders, but we've had some administrative departments and teams raise their hand and say they need code lavenders. And I think one of the greatest things we've done during the pandemic and are now implementing is a compassionate leave policy. We had frontline team members design what was a better way for us to support team members with grief and bereavement. And of course, grief being from multiple sources, not only the loss of an individual. And we now have a compassionate leave policy that is very similar to a family medical leave. A team member can request up to 12 weeks off. They can use it intermittently or in blocks of time. They can use their paid time off, a sick leave reserve bank that we have, as well as time off without pay. So they can have the time they need to recover, rejuvenate, process, and tend to the needs they need to individually for their grief. And we have done a lot of things also to normalize mental health in our workplace. During meetings, having a mindfulness moment, such as Rodney did at the beginning of his presentation, talking about how people are feeling one-to-ones and in business meetings. We've been teaching a lot of meditation and other techniques that can help individuals reset. And our managers are using them. And we've had one manager, she gave us feedback. Yes, I got anxious. I just did one of the techniques. And now I have taught other team members to do that. So when they're in the field and they need to reset or invest in themselves, they can. We're hoping that all of these things will help us be more sustainable and reduce our absenteeism, engage our workforce, and improve productivity. We believe they will all come back to us in a vibrant workplace. Next slide. And lastly, I just want to share a few things that we are doing to make sure that we do have the most resilient workforce for the patients that we care for. 24/7 call center, a support center that families can call into, as well as clinicians can use them to back up them for follow-up visits, things that need to be done so that they can end their workday when it's supposed to end. They have a care team that can follow up remotely and support them with their work to care for patients. At one point in time during the pandemic, we talked about taking the individuals in the support center and putting them in our crisis level response. But our team said, no, they are our crisis and catastrophic team. We are expanding the use of non-licensed team members, and we are working with other partners, skilled nursing facilities, as well as EMS for paramedics and EMTs. Medical equipment companies have providers. Our funeral homes might even be able to help us. So looking at how other partners in our community can help us be available for our patients and the non-licensed team members, whether it's scribes, community health workers, homemakers, others, to support our professionals so they can always work at the top of their license, and that we cannot use unlicensed team members when we need to. And I added our last bullet. We know that we need to do a lot of legislative and regulatory work at our state level so that our state will allow us to use some unlicensed workers or different licensed individuals. For example, paramedics right now have to work under the direction of an emergency medical physician or emergency medical director. And if we wanted to use them to help us support patients with symptom management or pronouncement of a hospice patient at home, what regulatory or legislative levers do we need to pull and work towards so that we can integrate them into our workforce better? And with that, Susan, I'll turn it back to one of our other panelists.
Thank you so much, Liz. Yeah, we again look forward to hearing more about the interventions that you've had experience with. Now we'll turn it over to Dr. Shreya Kangovi founder and executive director of the Penn Center for Community Health Workers and associate professor in the Perelman School of Medicine. Thank you.
Thank you, Susan, and thank you everyone for having me. I actually don't have slides. I just wanted to make this more of a conversation. And I'd like to start by picking up on Rodney's remarks. When I closed my eyes and pictured who we have lost over the past 18 months, I saw mostly Black, brown, or rural white people. These are the people in our hardest hit communities in America who have been seriously ill, who have been dying at startling rates, not only of COVID and its effects, including deferred preventive care, mental health challenges, but also longstanding issues like food insecurity, police violence, disparities of every kind. We talk about these issues disparately, but really I think that they are all symptoms of an underlying pandemic of injustice that is not novel, that has been with us for centuries. So I want to start us off by kind of taking a step back and asking what maybe is an obvious question: what causes health inequity? And I've been thinking about that a lot over the past couple of years, maybe the last couple decades. And it strikes me that health inequity is really a psychological condition that affects those of us who are privileged. And it is psychological because it takes forms such as racism, group narcissism, xenophobia, savior thinking, which is a big problem that we have in healthcare. And those are psychological distortions. So those psychologies make their way then into policies, whether it's federal housing policies, things like redlining, Medicaid coverage policies, or our clinic no-show policies, or institutional hiring practices. Those policies then shape the distribution of wealth and power across our institutions and our society. That shapes living conditions, which we often call social needs now. That affects behaviors, and then that affects health across all sorts of different domains. So when we think about health inequity that way, I think it really challenges us because we tend to have conversations about health inequity that are quite othering, where people on the left-hand side of the equation, if you will, people who are privileged, talk about how can we help and fix those people who face inequities. But I think actually this sort of framework of, pointing to privileged people as sort of some of the root cause here allows us to understand that in order to improve health inequity, we need to transfer power, actually. It's not enough to just address unmet social needs or navigate people, even with the best of intentions. So to whom do we transfer power? What does that look like? And so now I want to introduce maybe the protagonist of this story. This is someone called a community health worker. Many of you may have heard the term, but let me define it just to level set. So community health workers are trustworthy people who share life experience with the people they serve. They come from the same communities, geographic or otherwise, as the people they serve. And for the past 100 years, at least in America, they have been hired by community-based organizations, food pantries, churches, public health departments, primary care practices, to provide a range of social support, advocacy, coaching, and navigation to people in their communities to improve health. So there are three elements of the definition of who a community health worker is that I just want to punch and make sure that we get. Because the term is often co-opted or misused. The first element is these people share life experience with those whom they serve. So what that means is that they are a diverse reflection of America's hardest hit communities. 65% are Black or Latinx, 23% are white and often living in rural communities or lower income, 10% are Native American. They may not have extensive formal schooling, but they do have lived expertise of racism, of injustice, of financial hardship. So that's the key kind of first characteristic. The second is that they are trustworthy. I've shifted from using the term trusted to trustworthy because trusted implies that people just trust somebody that looks like them or that is their neighbor. And that's not true. That's not giving people enough credit. You have to be trustworthy. Well, how does somebody become trustworthy? In best practice programs, community health workers are selected on the basis of their personality attributes, things like altruism, empathy, listening skills, and non-judgment. So then they are able to become trusted because they are trustworthy. So shared life experience, trustworthy. And then the final attribute, I think, of community health workers is the approach that they take to serving individuals and families within their communities. They do not talk at people. They don't just do social needs checklists. They listen to people. They get to know their life stories. Mrs. Jones, tell me who you are and what you think you need in order to live your best life. And then they do those things, whether it is planting an urban garden, connecting to high quality primary care, or advocating collectively with local police. They are the power grid, not lampposts. We often think about serious illness or just generally health solutions in this country in terms of disease silos or domain silos, navigation, care coordination, advocacy, or opiates, maternal child health. Community health workers don't think that way. They see the person before them or the family before them. They ask what they need and they do those things, and they cross-cut domains and conditions. That is part of their power. I think the other part of their power, as I mentioned, when we think about the trajectory of health inequity, community health workers can intervene at all stages of that trajectory. Yes, they can work on the right-hand side of the equation. They can navigate and bridge gaps with health teams and improve health outcomes. They can coach on behaviors. They can address unmet social needs, but they can also keep marching upstream. They, by definition, if we transfer power to community health workers, we are reshaping the distribution of wealth and power in our institutions and within healthcare and public health. Moving up one step further, policymaking. Community health workers are expert policymakers because they are often end users of the policies that are made. Who better to redesign SNAP than someone who has been denied at the checkout counter? And then all the way upstream, something that I'm pretty excited about is we are now starting to innovate with community health worker-led anti-racism and social justice innovations. At Penn Medicine, the CEO and several other members of the C-suite now have community health worker mentors who can train them on what it's like to live with some of the inequities that we are trying to solve. So I want to transition now and talk a little bit about the science behind this workforce, because I would have to say that this is one of the more evidence-based workforces in health and in healthcare and public health. There have been multiple randomized control trials that have proven that community health workers can move the needle on things that we are talking about in this meeting today, from improved chronic disease control, cancer screening, access to and quality of care, reductions in hospitalization, and the best available data we have on this suggests that because of these outcomes, particularly reductions in hospitalization, community health workers can save about $4,200 per Medicaid beneficiary. And there's a $2.50 return on investment for every dollar invested in a community health worker program within the fiscal year. So the science is actually quite compelling on this. How is the next question? How do community health workers do all this? What is behind some of this magic, and how can we ensure that this is scalable? Because there's a broad range of community health worker programs out there, and I think some of them have been able to achieve some of these results, and then others haven't. And so, what's the difference between successes and some of these programs that are still trying to get it right? My team and I, that's kind of the question that gets us out of bed. And we've spent the past decade at the Penn Center for Community Health Workers trying to explore this question of how do you do magic with consistency? We started out conducting about 1,500 interviews with patients on bedsides and porches and shelters, asking them, how would you improve, what makes it hard for you to stay healthy, and what should we be doing differently when we design a program like this? We also studied past community health worker programs and tried to understand, what has worked and what hasn't. And so we took all of that and built Impact, which is a standardized, scalable model that really solves for some of the historic challenges, turnover was a historic challenge. So we developed hiring toolkits that allow us to select for those trustworthy individuals that I mentioned earlier who have that shared life experience. Playbooks and infrastructure so that community health workers are able to have that person-centered work practice that I talked about, where they get to know people's life story and do what they need in order to improve their life. Compensation, supervision that is supportive and from people who understand how to work with community health workers that may or may not be a clinician. So all of these elements are really critical. And this is kind of on a programmatic level allowed us to build out this program and replicate it across 20 different states. And I think that experience of running the actual care program, particularly in the last 18 months during this pandemic, has been very powerful. I really kind of admire the comments that the speakers made before me about how they took care of their teams during this pandemic. And I won't repeat them, but I will say that co-designing with our frontline workers has been critical, and making sure that their voice has been included in decision-making, in design and delivery of healthcare at all levels. So the final kind of piece that I want to talk about is scale. How do we take what we are talking about and think about solving for the challenges that America's facing, nationally? There's two components to this. One, I think, is standards, and the other is financing. So, as I mentioned, the science and experience that a lot of people have with community health worker programs over the past 100 years has given us a sense of what we need to do to try to get these programs to be as effective as possible. And over the past year, my team has partnered with NCQA, the National Committee for Quality Assurance, as well as the National Association of Community Health Workers and other stakeholder organizations across the country to try and develop, to try and address the question, what do community health workers need in order to do their best work? We held listening sessions with community health workers all across the country. We reviewed the literature, both domestic and international, and just released a white paper a couple of days ago that point to what organizations need to do to set community health workers up for success. It goes back to some of those same lessons that I talked about a moment ago: hiring authentic community health workers, training at all levels, not just a certification for community health workers, but training for supervisors and program directors, fair compensation, supportive supervision, manageable caseloads, and allowing community health workers to take a person-centered approach. So this is critical because these different domains could form the basis of national standards for community health worker programs and could be important guardrails for federal funding. And not only that, they are a win for this workforce. Other speakers have talked about how direct care workers and community health workers are no exception, are often exploited in their work. They are underpaid, they have caseloads that are unmanageable, they have very little supervision. And so by creating these programmatic standards, we're not only pointing to quality, but labor advocacy, in my opinion. The last piece of this is always the money, right? So, community health workers have, I think, always been a good idea for the United States. Now they are indispensable. COVID has chased healthcare out of the box and it's brought it into our homes. I like the framing of this meeting because we're talking about tech and workforce. We often talk about tech and pay for the tech much more than we do for the workforce. But unless we have the people to meet patients, individuals, families where they are, to build relationships, to actually address the messy root causes of poor health, we are going to leave a lot of Americans out of modern healthcare and create a new era that's just as expensive and narrow as the last. And so I think, along with the other workforces that you've heard about today, community health workers are central to this. They are people, like I've said a few times, with lived expertise of health inequity and injustice. And so centering our future of healthcare around them is about transferring power. And that's what we really need to do to address inequities. They can build the relationships that need to be built. They can address social determinants. They can relieve workforce strain. They can reduce health spending and certainly improve health for people with serious illness and prevent that serious illness. Yet, it's crazy if I tell you how many community health workers we have in the United States right now. There are only about 80,000 community health workers compared with, as we've heard from Dr. Larson, 5 million nurses, 3.8 registered nurses alone. And so, you know, we have to ask ourselves, why is that? And I think, you know, community health workers are often overlooked because they are people of color. They are often women. They are maybe from rural communities. They may not have a lot of letters behind their names. And we are still us, you know, the same forces that created health inequity are causing us to overlook community health workers, and they're not often in the room. And so as a result, they don't have a systematic way of getting paid. They typically rely on a patchwork of grants and pilot funding. Medicaid funding, when it does apply to community health workers, has been pretty narrow and tends to skew towards clinically trained community health workers who may not actually be that authentic, natural caregiver within the communities doing clinical work. And, you know, by this point, I think I've convinced you that that isn't really the core of who community health workers are and what they do, and it's not aligned with the best available evidence. So we've been trying to push for broader Medicaid coverage of community health worker supports and aligning that funding with quality guardrails, such as what NCQA described in its white paper. And this will ensure that the work is high quality and that community health workers aren't co-opted or over-medicalized. Some of this policy work is getting traction with CMS, with Congress. We've been fortunate to partner with Senator Casey, who's working on legislation that would create discretionary funding for community health workers, as well as potentially an optional Medicaid benefit. President Biden and his campaign proposals committed to creating 150,000 community health worker jobs. So I think that we have some momentum. There is a blind spot here, and I think if we talk about in the Q&A, we can have some frank conversations about why that blind spot keeps getting perpetuated. I think it has to do with who's in the room and who's not in the room. And you know, just to close with Dr. Boulware's framing, the story of serious illness is a story of inequity. Inequity is complex. It's woven of many, many interlocking threads, but I believe that centering and hiring and empowering those who have lived expertise of that injustice is the only place to start. So I look forward to the Q&A. Thank you so much for having me.
Well, thank you. It has been so great to hear from each of you. We thank you for contributing your expertise to our conversation today. I would like to remind the audience as we enter the panel discussion to submit your questions using the Q&A box rather than the chat session. So we will be keeping an eye on that Q&A. So at this time, I'd like to invite each of our panelists to join us. You can turn on your cameras and we can enter into some dialogue here. So much to consider and talk about. I'd like to first start with some discussion around wellness. So Dr. Tucker mentioned the Circle Up framework. Liz addressed the Compassion Project. Can you expand on which interventions you think have the greatest impact on wellness in our workforce?
I really appreciated Liz and the comprehensive list, because I know that her organization's always been very innovative and comprehensive in looking at, you know, what we do. And so I think to some degree the verdict's still out. A lot of the things that we know are sources of burnout are more institutional, operational, and so things like flexible work schedules, equitable compensation, value, I love the, you know, concept of the compassion time. What was it, Liz? The compassion time, you know, away. Those are the things. It's not all money. And I think that we have to look at those institutional things. But so many times when we talk about resilience, it gets put back onto the individual to say, well, you know, use the stairs, you know, eat less carbs, you know, do yoga. You do all this and you'll be, you know, you'll be better. And so I liked a lot of the things that Liz talked about. For our team, we had to find something in the moment. And that's why the circle up and the debrief and having grace and being flexible. Okay, I need to cover that because you've got to get home because you're homeschooling and, you know, your spouse. I mean, we had to do something in the moment. And that was really the most effective because, again, it was immediate. It was more one-on-one. And I think that's what kept us what kept us going. But I like all of the things that Liz talked about too.
What we've been finding in long-term care is that the cute things that are done, like a tree of, putting posters on a tree about what matters, or having a pizza party and those things, they're fine in a culture that already feels that they're being supported. And yet I've seen people say, oh, they're just, that's fake. They're having an ice cream social for the staff. They're bribing us. Those kinds of things.
They brought us cookies. They brought us cookies.
And it seems to be that there's a cultural necessity that there has to be a sense of trust and open communication, or else it feels like they're just doing it in lieu of doing the right things, like appropriate salary or whatever.
If I could just say, I think it comes down to power sharing again. So often decisions in organizations are made by people who look or are different from the people on the front lines. And then when there's an ice cream social, that stings. And so part of wellness, especially at a time when a lot of us have felt a lot of powerlessness, is to make sure that people have voice in the decisions that affect them.
And I agree, those, some things not done with a whole organization and supports behind it will seem very trite and meaningless. And, we have really worked hard it's individualized too. The manager understands what the individual person needs, because that's going to be different for all of us. And creating empathy and emotional intelligence in our managers has really been key, and giving them permission. Absolutely, you can make exceptions for someone. You can make exceptions for everyone. And how do they feel they have the latitude to do some of those things? We actually use the front line to create our compassion leave policy. And I was a little afraid at first, are we going to be able to afford this? But you know what? They're good people. They know we have to be sustainable. And they figured something out that means the right thing to our caregivers. I just think we need to lean into that. And so much of healthcare falls on the backs of our frontline clinicians. And what we even were talking about this morning, how do we get to when a nurse is supposed to end their shift, and I say a nurse, any of our team members, end their day at a certain time, that they know they can end it, that they don't have to be available for another call or to check in on Mrs. Jones because they're worried about her tonight, that we have our standard processes and procedures that anyone can pick up and cover the rest of the work that they feel responsible to do, that they have workers they can trust, or other systems in our organization they can trust to continue the care they want our patient to have.
Now, Liz, I think you're right that people need some sense that they can predict their schedule, particularly if they've got family at home or they have a babysitter who has to get home or something, on the one hand. On the other hand, we can't have frontline staff who walk out because it's, X time. And most staff are very willing when it's clear that there's a need or whatever. But another thing you said that really struck me is that I read a study recently about nursing leaders, administrators, et cetera. And they asked nursing leaders, how much influence do you think you have on the job satisfaction and the quality of care on your unit? And they all said basically none. And then they asked the staff, and the staff said, that's one of the most important things to me, is how the leader sets the tone and, what expectations, and mostly, does he or she have my back? Do I feel like I can not be out on a plank by myself? So I really think we have not focused as much on training our leadership for any healthcare discipline than we could, because people just get upgraded and they get go up in rank, and they're not necessarily trained for the kinds of skills that you need to be a good manager, a good leader, and they're trained to do other kinds of clinical stuff. It's a whole different skill set. So we really need to focus, I think, on our leaders.
I think that's, Elaine, I will tell you that is incredibly important, because I mean, the data before, the data during, and the data after of individuals that leave organizations do not leave the organization, they leave the manager or they leave their leader. And you are exactly right, and emphasizing that and role modeling, and given there's some very small things, you know, that individuals can do. And they're not, maybe they're not trained to do it. Maybe they're not skilled, maybe they're uncomfortable, but that is really, you know, really, really important.
Yeah, let me tell you a case. A colleague of mine who was for about 4 years the nursing manager of a large emergency department in a large healthcare system in New Jersey. And he had 5 managers over 4 years. Some of them he had horrendous trouble with. And then when the pandemic started, because he was the nurse manager, whenever anybody called in sick, no matter whether it was days, nights, or whatever, he would go in and cover for them. And we were worried because my husband and I are friends of the couple. And his spouse, we were worried that it was really affecting their marriage. I mean, it got to a level where he had to rent a hotel room next to the hospital so that he wouldn't have to commute, because he was working 60 hours a week or so. So he went into, he was, you know, he'd done this about 8 or 9 months. He went into work extra on the weekend on the night shift. He found out from his supervisor that 2 of the staff had called in sick, and they told him that he'd have to do with the staff that he had. He said, it's not safe. It's going to be dangerous for patients. We can't manage this big emergency room with the staff we have. They said, too bad. And he did something that to me was appalling as I thought about it. And that was, he said, I can't take it anymore. And he walked out. He quit the job. No notice, no anything. Now that you could argue was unethical in itself. But on the other hand, this is the kind of moral distress that our healthcare workforce is in, because he had to decide whether to keep enabling the system to have insufficient staff and sort of covering for it by working, or endangering the safety of people by leaving. And it was catch-22. He couldn't win. You know, what's the right decision? I thought it was horrendous that he walked out, and I thought, boy, you're going to burn your bridges as you go along. But I can understand it. And tonight I'm involved in a webinar on moral distress in nurses, but it's the same for physicians as well. And the other thing I'm hearing from one of my chief nursing officer administrator colleagues is that the nurses now are being laid off because they're the largest proportion, or a very major proportion, of acute care costs. The nurses counted in the bed price. Okay. So the hospitals are losing money, and the first thing they do, first the nurses are heroes, and now they're being laid off. And my chief executive officer, VP for nursing in a large healthcare system in New York City, said there's nothing she can do about it. It's above her. So that's another moral distress kind of thing. And then finally, the nurses are saying that they're caring for patients who are critically ill and dying of COVID, some of whom now refuse to get vaccinated. And so they're having to take care of people whose philosophy is different than theirs. And that's the way it is for all of us, and it should be. But it causes more distress.
I think, Elaine, that's back to my point about the decreasing empathy that I experienced. That's exactly what it is. Because we've all taken care of patients who maybe made lifestyle choices or had, things in their life that, had they not done that per se, then their life and their health might have been differently. but that's sort of in a judgmental, non-judgmental place that you come from. But this was different. This, and especially the second surge, was different about the empathy. So when, I got the diagnosis of, the Delta variant spouse with bilateral pneumonia, I went through the anger. It fractured family on both sides from individuals who were not vaccinated. I'd never had thoughts of decreased empathy like that. Like, yeah, sure, you're going to come in now and you want the antibodies or you want the ventilator space, but for unclear misinformation reasons, you don't want to be vaccinated. And I could get it. I could die also, from that. So it was a totally different empathetic shift that's going to take a while for folks to get back to some of that empathy and moral distress. How dare I feel that way? How dare I even have those thoughts?
As a healthcare provider, right?
As a healthcare provider.
Yeah, and I guess you could say the same for obesity, drug use, smoking, all those things. But the difference is the sort of major up and down shift that's gone on with the pandemic, the emotional, the PR, thank you for your heroism, and then all of a sudden you're laid off sort of thing.
Yeah, I do like the highlighting of leadership and the work climate as being a significant part of well-being and not just the role of the individual. And Liz, you mentioned having the frontline participate, in the creation of your policy, which is really amazing. There is a question about burnout, and I'm just wondering, the professional quality of life scale was addressed as a measure of how folks are doing. Any comments around other types of assessment, how you can differentiate burnout from other risk, of waning empathy and compassion fatigue?
I'm not sure how you differentiate them. They're all sort of on a spectrum, sure, if you will. But certainly for nursing, there's been burnout way before COVID. And against the public knowledge or different than the public knowledge, there actually are not that many nurses who retire early. And often they're one of the major care or, financial providers for their family. So, but they transfer jobs a lot, particularly when they're younger. And retention, training a new frontline staff person is very expensive. And orientation sessions or orientation for new nursing, like in intensive care, they're a year sometimes until they can get to the point where they're really highly skilled. And then if they leave in the next year, it's a huge money drain from the healthcare systems.
Sure. Dr. Kangovi, you raised various disparities in the health workforce, and I wonder if there are additional comments around supporting a diverse and inclusive community of workers in healthcare.
Yeah, there's a lot to say there. I think, we have to kind of look at ourselves first. And one of the things that we tend to do as clinicians, is we do hog the ball a little bit, right? We want to kind of retain control. We're quite clinician centric. We talk about, a lot of this conversation is quite clinician centric, and it's just our habit as clinicians. And we talk about, unlicensed workers and the top of the license. And we there are these filters that are based in things that we don't realize it, but they're a little bit kind of code switched. When we think about who can, I think it dates back to an era of thinking about health as purely a clinical output. And that health was something that was purely driven in a biomedical model. And so in order for people to intervene on that, you need extensive training. And so we think about the workforce that way. We think, how are you trained in order to do this? But we know a lot more than we used to about what creates health. It's not just medical care. It's, in fact, That's a much smaller part of the puzzle than the social and behavioral factors. And so when we now think about, well, what do we need to move the needle on health? It's not people with, thousands of hours of biomedical training. It's probably a lot more of people who have that shared life experience and who are empathic and who can be flexible and address a range of different challenges that people face, and who can also teach us to sort of upend the system. Why haven't we shifted to that in our workforce, in our conversations? We'll look around the room. They're not here. And so I think that's a challenge for us who are on the panel and who are in the room and who are in these rooms of decision-making and power.
Yeah, I agree with that wholeheartedly. Last year, when we thought within our field about the 4 domains of suffering that we promote, physical, spiritual, psychosocial, emotional, we began to have some conversation around adding cultural suffering because we think that's probably the 5th domain. And it's been pointed out in 2020 and 2021. And something that we have to take away is the impact of COVID on, communities of color. It points out the disparities, and we have to just not look at it as an epidemiologic phenomenon, but as something that we have to change and bring that into the conversation.
I think that's great. And, what's the hardest part of this conversation is not thinking about disparities in the abstract, but as Rodney mentioned, there are people who impart cultural suffering on other people and using the actual words like, racism or injustice, and looking at how some of us benefit from that. That's really hard because we want to believe that we are heroes and we kind of go throughout our day and we save the world and we deserve what we have. And, maybe that's true. But when you start to work with, folks like Ashley Harris or, other community health worker colleagues of mine, they have tremendous resilience and empathy and grace. And it starts to make you wonder, like, am I the most deserving of this job, of this voice that I have in this room right now? And I think that's the tough kind of stuff that we need to be talking about.
Yeah, thank you for raising these issues. And I think about people with serious illness in particular. That's been the focus of our workshop. And you mentioned the kind of 3 core criteria for community health workers is having a shared life experience, trustworthiness, and a focus on what matters most. And I think in particular for the population that we care for, that's just so important. I was intrigued by the mention of community health workers mentoring other folks in traditional health disciplines or leaders. So what can be learned and what should we be learning if we're physicians, nurses, social workers from your community?
That's a great question. And the term learning is such a loaded one. And so I think it's the way that we've structured this is more experiential, to use sort of a new age term. I'll just tell you what happened. So there's 5 leaders who are, or execs who are partnered with 5 community health workers. They meet in a combination of groups, small groups of the 10 of them, or one-on-one with their mentor. And it takes place over a year, and there's a trajectory to it. The first session, everybody just shares their life story. And you go around the room, and pretty soon you're seeing these aha moments where, community health workers talk about having been homeless or, having lost a son to violence, or, one of my colleagues talked about being pulled over by the police 23 times by the time he was 30 years old. And he's like the best guy ever. He's like a little league coach and he's a sweetheart. And then you hear from the execs, and their life stories don't sound like that. And so there's this twofold recognition, I would say, more than learning. It's like, what has shaped our life stories to be so different? We can know that intellectually, but learning it humanistically feels different. And the second is, it's not a pity party. This isn't poverty porn or trauma porn, because these are the best among us. I think about community health workers as if you hold up a mirror to our hardest hit communities and reflect the best of us, that's who community health workers are. So you leave that first session not feeling sorry for, Ashley or Orson or whoever. You feel like, wow, maybe I'm not the best person ever. Maybe I'm just okay. And these people are the best people ever. And so from there, it's more of an opening to then discuss things like, they go out with their community health worker mentor, walk through their neighborhood and learn about, well, this is where redlining happened. And this is where Penn has disinvested from the community. And this is where there used to be a Black-owned business, but it's gone now. There's bidirectional shadowing. The community health workers shadow the execs and provide some notes on, their day, who's in the room, look around you, who's not in the room. How are we talking about people? Are we talking about people clogging up our hospital beds? And so it kind of goes through these very kind of shared experiences. And then the final product is that they work together on system redesign. They pick a project and the 10-person group does it together. So for example, redesigning our institution's vendor relationships. So that's kind of the architecture of it.
Great, thank you for sharing. And I recognize that the concept of training could be loaded because we do have competencies and criteria for many of our disciplines. But your comments remind me about what Liz said earlier about cross-training within your organization and the interdependence that you had created. And so, I think one of the impacts of COVID has been to see this sort of cross linkages across various types of disciplines. And I wonder if you could comment on that further, Liz. What type of training was needed to ensure that our workforce has the necessary skills, and thinking about community health workers or the patients themselves and how we can learn across, the entire care paradigm instead of just our traditional model of what the healthcare system includes and excludes.
Yeah, well, Susan, first I'm going to reflect on one thing that we realized is we wanted to begin our hiring process differently. And we looked at what were core competencies anyone coming into our organization needed to have. And we based them on our core values, and one being teamwork. And we went, okay, what's a competency of teamwork? And again, we used some frontline team members to tell us, what does a competency a good team member has? And they said, interpersonal savvy is what we came to. That I have team members that understand what other team members need to be our best team. And so we've begun to hire for that. So we're looking at individual natural tendencies and competencies people have that come to our team that make them good to, in this case, to answer your question, to retrain to something else. So if they come with that interpersonal savvy, it makes them a better team member. And if we have systems and processes in place, it makes them easier to fill in another role. And we had been on a journey of standardization to be enhance our culture of safety and other purposes that really served us well for COVID, that we have our competencies and checklists and all those things that we need for healthcare. And, when we have a workforce that really has this interpersonal savvy and wants to help out and give, the actual training became a lot easier. Now, certainly there's certain things that you do have to have a license to be a physician or a nurse to do, but there's so many things. For example, our nurses were ordering medical equipment or other things. And you don't have to have a nurse license to dot those I's and cross those T's to get the medical equipment in the home at the right time. So I don't know if I'm answering the question. Yes, it was a lot of retraining, but we have roadmaps in place, and we could pull apart what part of the competencies one of our physicians had could be assigned to someone else.
One of the questions that occurs to me is, to what extent can you teach and learn interpersonal savvy. And I really think that Shreya's example of experiential learning, and I'd call it learning for sure, it's experiential, but it's definitely learning, probably the best way to learn, is that people develop an appreciation for the things they didn't know others did. So sort of the trail a physician or trail a nurse or trail a community health worker is very helpful. For about 12 years, I taught a course to physicians and graduate nurses and ethicists. It was an interdisciplinary course on building interdisciplinary models. And we made them come up with a project as a team, and we split them off so that they weren't all one discipline. At first, they hated it because they didn't want to mess with learning or, working with a group with whom they didn't identify. But by the end of it, pretty much universally, the students felt that it was the most valuable thing, was to have to do a project together. So it's got to start, whenever possible, early.
Yeah, just a quick add-on to that is, sorry, Rodney.
Go ahead, Shreya.
Oh, okay. Yeah, I would just say, we often handicap ourselves in healthcare because we don't focus on hiring. We're so training obsessed. And I just put an article in the chat that I think hopefully can challenge that. We wrote it kind of with the Moneyball framework. If you guys remember that movie, you want to hire for traits and train for skills. And we need to rethink how we're doing that in healthcare.
Yeah, one of the things that I was going to say is that fundamentally, this is sort of to your point, Elaine. After about, I've been involved in a lot of leadership development activities and done sort of my own leadership, physical exam every year, just about. Is that many times when you were talking about, I think Liz, you said interprofessional savvy or interpersonal, savvy. Individuals, in my experience, don't spend near enough time on looking at their own individual strengths, weaknesses, capacities, preferences, and we teach them sort of what the, I guess, classic, read the book model is of good leadership, but they don't know themselves where their comfort zones are. They've never done a Johari window. They've never done a strengths finders. They've never done a DISC assessment. They've never probably had a 360, and done these things to look at their own exam so that they will know and be able to flex, because that's the way they get to success, is to be able to look at their own inner leadership styles, values. So we kind of hire for will and value and then train, for skill and growth. Because if they don't look and they don't know as a leader what their DNA is, and then it's going to be, they're not going to potentially achieve as much success in a team, out of a team, as a leader, or whatever.
That sort of builds on Shreya's point about now I forgot what I was going to say, what your point was, but I'll get back to it.
Change management. I mean, I think, the change management and acceptance of uncertainty.
Oh yeah, now I remember that the first thing that's necessary before we can recognize that we have that, before we do something about privilege that we just have by virtue of being white, for example, or virtue of whatever, being in a highly respected professional field, is to be aware of the privilege that you have. And it's the same, I think. I was in a session with about 35 people a couple of weeks ago, and we were asked, what kind of power do you have? And about half the people in that meeting said, I don't have any power. And I'm thinking that, that's crazy, because you have one really positive or really negative, or somebody's very strong, no matter what their position is, they've got influence and power. And, it's not positional, which some people also have, but but the sense of your own individual influence and power.
I don't know if Susan wants to rein us in because we're going in a totally different direction here, but I think it's important because we're talking about power. And when we're talking about that, that's the root cause of poor health for a lot of people. I've been studying a lot about self-enhancement and self-protection. And I just think, as we talk about these leadership issues and Rodney, your point about how a lot of leaders don't look in the mirror, that's not an accident. It's really hard to look in the mirror. And, Elaine, your point is when people deny their own privilege and power, that's a form of self-protection and self-enhancement, because then you get to attribute, there's this fundamental attribution bias, which is that we all like to take credit for the good things that happen to us and all like to shift blame for the bad things that happen to us to things that are out of our control. And, not acknowledging our own privilege is the first little step of that pathway.
Well, thanks, Shreya. Yeah, I think it's a really rich discussion. It's not often you hear talk about power, and I know you introduced that concept to us, but in traditional healthcare settings or trainings. And, we think about leadership, but often training is done by discipline, right? And when we think about care for people with serious illness in particular, it's team-based. So the first step is looking within ourselves and our privileges and even how those privileges may benefit us or protect us, as you mentioned, but also that cross-linking with our other team members to understand their experiences and their power as well. And I think implicitly in the system, we as a physician, we all learn who has power as we go through our training. So I think in some ways maybe the wrong things are reinforced over time for folks. I do want to ask a question about work flexibility because that was brought up by Elaine. It was something you wanted to expand on around levers for work flexibility and attracting or retaining healthcare workers with different types of scheduling changes. I wonder if you can comment on that.
Yeah, unfortunately, it's not like many of us. We have the privilege and the choice of continuing to work in a hybrid way. A lot of us can do our work from a distance and virtually, but that's not the case for the frontline workers. So you can't have flexibility when you don't have enough people, period. And, so it goes back to this really basic systemic problem. I don't think that there's a short-term answer, but there are systems that have developed ways of making scheduling more flexible, 2 or 3 longer shifts per week versus coming in every day, all those kinds of things. And there are places that have the ability to give people a little bit of option, but I don't know, Rodney, you're there, or Liz or Shreya, what do you think?
I think it's going to be one of the greatest challenges because when we talk about power and privilege, your leadership and many folks may have the power to work remotely, the privilege to work, remotely, where, like you said, Elaine, your front line, some nurses in research or some nurses would be able to work, remotely. Maybe they're in leadership roles, but your frontline nurses, bedside care can't be delivered remotely. Bedside care can't. We can do lots with telehealth, which we're going to talk about. But I think it's going to be one of the greatest, challenges. And I think the for lack of a better term, early career and early professional individuals are going to have different expectations about work-life integration. And so I think it's going to be the great dilemma. We were disrupted. I couldn't have imagined 2 years ago having my entire staff on this hallway, our entire staff, not all here every day, running into each other in the hallway, being able to have live meetings, walk next door for a quick question. And now we're 3-2, 3 on site, 2 remote. Works great, particularly for our young families and folks have that flexibility, things are getting done. Things are getting done. Productivity's good. Wouldn't have ever even thought about that, but it's still going to come with a whole host of potential issues.
Yeah, another ethical dilemma that's stuck its head up lately is that there's this debate about whether mandate vaccinations in healthcare settings, and most or many places have, and I personally think they should. But some places have been hesitant, particularly in long-term care and home care, because it's sort of like, well, we have a proportion, maybe 20, 30% of our staff that won't get or don't get vaccinated, choose not to. And they, if we mandate vaccination, we don't have enough staff. Well, either way, it's a difficult decision to make. Do we allow people to work unvaccinated if they're tested on a routine basis and so forth? Or do we say you get vaccinated or you're out of here?
Liz, I was going to add a quick thing to the point about flexibility, but I just want to make sure, because you haven't had a chance to say anything from.
Thanks, Shreya. I think there's a lot to think about, and I think we're getting close to time, but I do actually want to give you the opportunity to think about flexibility. I was reflecting that the next session is on telehealth, and so I think it's while it provides a lot of flexibility for some workers, as we discussed, it doesn't offer the same flexibility for everyone and can create more division across the workforce. And so I didn't know if you had a comment about that.
Yeah, just real quick, like you can't do that. I think that's where we have to really keep our focus, is making it equitable. So what we've done is take an equity-based approach to return to work. We were all working virtual for a while. And then when we returned to work, we were really careful not to say, okay, the frontline folks have to be in person. The back office people can be at home, because that's just not fair. There's going to be disparities across who's frontline and who's not. So we all come in, similar to Rodney 3 and 2. And that's important. Like, I think people can suffer, but they can't feel like they're getting screwed over. Like, this is a lot about justice and fairness. I think the other thing to keep in mind is, equity is, you have to actually solve for helping people who are disadvantaged even more. And when we think about, who our frontline folks are compared to, the execs, frontline people are more likely to be sick, to have family members or other, friends who are seriously ill, to be caregivers, to be dealing with secondary trauma when they're, for example, community health workers, when they're supporting people with some of these really complex psychosocial and mental health issues. They're the ones that, may have a secondary trauma. So if anything, we have to overcompensate for that.
All right. Well, it looks like we're at time. Thank you for the final thought, Shreya. So I want to thank all our panelists for participating in this conversation. It's very thought-provoking and sharing your knowledge with us today. And I will hand it back to Bryn to introduce our next session.
Thanks, Susan. Rodney, Elaine, Liz, and Shreya, thank you for this incredible conversation. I think you've taken us through an unusually honest and clear-eyed assessment of some of the systemic obstacles we have to supporting a healthy and effective workforce that's equipped to provide the kind of care that patients and families deserve. In our next session, as we've said, we will focus on the use of telehealth in the care of the seriously ill patient population. And I'm delighted to introduce Dr. Hayden Huskamp. She is the Henry J. Kaiser Professor of Healthcare Policy at the Harvard Medical School. Take it away, Hayden.
Thank you so much, Bren. I'm really excited to be a part of this panel today. While telehealth had been used in serious illness care before the pandemic, and some people were pointing at that time to telehealth as a way to improve access to care going forward, particularly in rural and other underserved areas, its use was relatively uncommon at the start of 2020. But as we know, that spring, in an extremely short period of time, out of necessity, telehealth was adopted across the healthcare system very rapidly. and clinicians and organizations who hadn't used it much before were trying to figure out in real time how it could best be used to maintain access to high quality care during the crisis. In this session, we'll discuss how telehealth has been used in serious illness care over the past 18 months and what lessons have been learned that can inform both how we might use it in future crises, but also how it might be used in standard practice in the absence of a crisis. We have three excellent panelists today. The first panelist is Steve Klauser. He is Program Director for the Healthcare Delivery and Disparities Research Program in the Patient-Centered Outcomes Research Institute, or PCORI. And he's going to talk about lessons learned from the portfolio of projects supported by PCORI across the country that are focused on telehealth. So I'll hand it over to Steve.
Thank you, Hayden. Appreciate it. I just want to say that what I'm going to do today is start out the session by briefly identifying some of the trends that have gone on in telehealth since the pandemic started, kind of building on some of the comments that Hayden made. And I also want to discuss a little bit about our portfolio. And I'm going to try to emphasize some of the enhancements that to our existing studies that occurred during COVID-19 that related to telehealth. And then I want to kind of discuss a little bit about an example in palliative care to kind of drill down on a topic that's of special interest to this group, and then describe some of the lessons learned to date from our completed studies, including some telehealth strategies that appear to mitigate disparities in care. Next slide. Okay, as many of you know, there's been a dramatic increase in telehealth during the pandemic. In-person visits plummeted and the use of telehealth rose. However, the rise of telehealth has not consistently increased over the period, as it appears that telehealth visits have really leveled off or plateaued, but at a level that's significantly higher than pre-COVID levels, since in-person visits appear not to have yet recovered to pre-pandemic levels. And telehealth has expanded considerably in primary care during the pandemic, but the growth in telehealth is really varied by specialty care, with specialists such as endocrinologists and urologists really experiencing high uses of telehealth, other than other surgical specialties like orthopedics, general surgery, and ophthalmologists, much less so. And when you think about the conditions that are treated, about half of all telehealth visits involve mental health care, at least in the early part of the pandemic. Now, this growth has been facilitated by reimbursement changes that were really barriers to telehealth in the pre-COVID period. And this includes changes like lifting site of service restrictions, licensure restrictions, as well as adding new covered services, and importantly, expanding parity in payment. And CMS has recently released its final physician fee schedule for 2022 and will continue enhanced reimbursement for telehealth under the public health emergency authorities. You know, we all know that disparities in health outcomes, especially mortality, were exacerbated by COVID. But as Ebony Boulware noted in her workshop presentation last week here, you know, most of these disparities really appear to be access issues and not really quality of care issues. So I think one would think that telehealth, by reducing time and geographic barriers, as well as being able to address these physical distancing that's needed to avoid COVID exposure, really might mitigate some of these disparities. So let's see a little bit about what comparative effectiveness research suggests about these issues. Next slide. Okay, this is, I think PCORI is pretty well positioned to inform this question due to our sizable investment in telehealth. As you can see from this slide, we've invested more than $500 million in 117 research studies, examining the comparative effectiveness of telehealth modalities and strategies, either to each other or to other forms of care delivery. And our definition of telehealth is quite broad and includes things like, you know, web portals, mobile apps, remote monitoring, text messaging, as well as the more traditional two-way video interaction of telemedicine, where clinicians and patients interact. And here you can see in the circle that telemedicine is about a third of the studies we funded in this area, but this percentage has been growing during the pandemic. Next slide. Also, about half the studies we funded are using telehealth to explicitly address disparities in access and health-related outcomes. And as this slide shows, these studies address diverse vulnerable populations, with more than half of these studies focusing on telehealth delivery in racial and ethnic minorities. And later, I'm going to share some insights from this group of studies that may be relevant to health organizations, clinicians, and patient groups. Next slide. Now, during the COVID pandemic, PCORI funded several telehealth studies that were specifically intended to address challenges of care delivery raised by COVID. There were two types of studies we funded. We leveraged existing infrastructure in our ongoing research projects to rapidly address this public health crisis by funding what we call research enhancements. And we awarded 19 of these enhancements during COVID. We also issued a targeted funding announcement that solicited rapid comparative effectiveness studies. And out of the 9 studies funded for this special solicitation, 5 were related to telehealth. Now, findings from our target awards won't be available for some time, but I will share results from at least one of our enhancement studies, as they have a requirement to provide actionable outcomes within a year that could help mitigate the pandemic. And just one other point about this slide, it does show some of the general areas that our studies address, with a majority focusing on addressing issues related to mental health and social isolation. And the second most common addressed issue is continuing to provide care to people with serious chronic disease. Okay, next slide. Well, here's one example of the studies that we have funded, one that I hope will be of particular interest to you because it addresses the challenges of delivering palliative care via telehealth. This study is led by Jennifer Tamel and Joe Greer from Massachusetts General Hospital in Boston. And the study is a clinical trial involving 1,250 patients across 20 clinics who have advanced lung cancer and need palliative care. The study compares the impact of 2 different models of palliative care, one that moves largely to virtual visits and another that maintains in-person visits, to see if they provide equivalent results on outcomes that matter to these patients. Now, the model of palliative care examined is based on Dr. Tamel's earlier groundbreaking research that demonstrated improved quality of life and lower mortality when palliative care was delivered to advanced lung cancer patients instead of usual oncology care. Now, as you can see in the lower left-hand part of the slide, there's a list of COVID findings because Dr. Tamel has received an enhancement award to take a deeper look into some of the key elements that are helpful when conducting serious illness conversations by virtual visit for advanced lung cancer patients receiving virtual palliative care during the pandemic. And they found, for example, the use of clinical visits can overcome certain challenges that occur with inpatient palliative care, including time, transportation, and privacy issues. And it's important for clinicians to build rapport for difficult conversations by practicing pace, increasing comfort and participation of the family, and providing technical support to the family and patient, and to be intentional or use what she refers to as webside manner during the video visits. And this includes proper setup and acquainting the participant to telehealth, maintaining a conversational rhythm, responding to emotion, and appropriately closing the visit. But they have also discovered that other considerations may require moving from telehealth to phone visits. These include persistent technical difficulties, lack of the prerequisite technology to actually conduct these visits, patients who are simply too ill to participate, or who find virtual visits just too technologically overwhelming. Next slide. I told you at the beginning, we would be also providing some lessons from our portfolio that would help you understand the evidence about whether telehealth is effective or not. To date, we have 24 projects that have published findings. What we see here is the evidence is mixed. While there are some examples of where telehealth was clearly as effective or even more effective than what it was compared to, there are even more studies, unfortunately, where telehealth failed to achieve the hypothesized benefits. And I think the takeaway about whether telehealth can be an effective delivery mechanism is, well, it depends. For example, technical issues can negatively affect the patient's experience, and long-term adherence to telehealth modalities like remote monitoring and mHealth are consistently poor. These speak to a common theme also that we see in these studies, and that is the importance of human support in navigating technology, as well as often supporting the user. Next slide. And so the bottom line is what I think these early findings seem to indicate that how technology is implemented is really critical to its success. Next slide. Well, this is my last slide, and I'd like to leave you with some special thoughts about how to potentially mitigate the negative impact of telehealth in exacerbating disparities in care. McCrory has been working with a group of investigators leading studies that are addressing disparities through telehealth, and they've examined lessons to date from about 35 studies in this area. Next slide. Okay, first, telehealth interventions that hold promise to reduce disparities really emphasize patient-centered design to ensure that the interface is engaging and meaningful to patients with disparities. Next slide. They also underscore the importance of delivering a culturally competent message that reflects the views and values of the patient. Next slide. And as mentioned earlier, the human component can be critically important to the success of telehealth interventions for persons with serious illness experiencing disparities in care. And delivering care through trusted intermediaries, such as local community health workers, like Dr. Kangovi mentioned, or peers, can be really helpful. And finally, next slide. Patients need to be assured that the information exchanged through technology is held to the same standards of confidentiality as an interaction might occur in the doctor's office. So what I want to do is just end with a note that McCrory's investigation of telehealth through research is still ongoing, and the themes of these early results could use additional validation and hopefully expand with more information. But we're hopeful that this portfolio of studies will provide evidence to answer a critical question about which telehealth strategies work best for which populations with serious illness and under what circumstances. Thank you.
Thank you so much, Steve. Our second speaker today is Jacob Strand. He's a palliative care specialist at Mayo Clinic, and he's going to talk about how his health system used telehealth and what they've learned over the last 18 months or so. Thank you, Jacob.
Yeah, well, thanks so much, Dr. Huskamp. And I'm not going to share slides today. I decided to, normally I'm a slide user, but I figured I would share really a few reflections and hopefully spend the bulk of the time pumping this back into our discussion. I think there's just so much here to think about. And I apologize, I'm out of breath. I was running down from a clinic visit earlier. And interestingly, that visit was in person versus video, and it actually had just switched over for reasons that I suspect many clinicians and caregivers find. Is there were issues with technology on the beginning, which required the family to decide to come in and be seen. And so I'll comment on that a little bit later, but just to note that hopefully I'm practicing what I preach, or at least what I'm willing to discuss today. Just a few disclosures on my end. So I consider myself in some ways an academic palliative care specialist, if only because I work within an academic healthcare system. And that gives me a sense of, I think, intense resource and privilege that many of my colleagues in other areas don't have. And so when I am giving lessons from our experience, it really is our experience in an area with a tremendous amount of resource put into telehealth over the past 20 months. But hopefully some of these challenges will then really hopefully be at least relatable to some, and hopefully we can use that as a starting point for further discussion. I work as the Associate Chair for Palliative Care in our Division of Community Internal Medicine, Geriatrics, and Palliative Care here at Mayo Clinic in Rochester. And so some of my role is wearing different hats, and I wear a hat of running a specialist palliative care program, which has a large consult practice in the hospital system, an outpatient referral practice, embedded oncology clinics, a primary palliative care inpatient service, and as well a regional hospice entity for about 200 patients under our care here in Southeast Minnesota. But Mayo Clinic also has practices in a number of different areas, including Mankato in Minnesota, Eau Claire and La Crosse in Wisconsin, as well as our referral sites in Phoenix, Arizona, and Jacksonville, Florida. And in my role as our specialty council chair, I've been working with our leaders in these various sites to coordinate and standardize our palliative care interventions. And so there were some pieces of this that were quite helpful as we started to build out telehealth very rapidly, or forced to build out telehealth very rapidly in the initial portions of the pandemic. And so, this experience that we went through, I'll probably talk mostly about what's come afterwards as opposed to how we navigated this, because I think that's a story that others can tell just as effectively, if not more so. But just from a background, we went from about 80 visits a year, and these were mostly in research settings doing telehealth, to about 1,500 video visits in 2020, and now we'll do about 25 to 30% of our visits in 2021 virtually, again, mostly in the outpatient setting. And this is in part because of patient preference. So there's an intense desire from patients to continue to receive care in a virtual capacity. Or at least some of those patients and some of them are maybe just the most vocal, but also because Mayo Clinic has a strategy to really grow rapidly telehealth and virtual capacities at all of our sites and in all of our practices, with obvious variation based on practice needs. I guess where I would reflect on and think about the perspectives on telehealth is that I think the perspective really depends on who you are and how you have encountered this. Having participated in some of the research studies that were just mentioned and continuing to do a lot of visits with particularly our oncology population virtually, I love telehealth. I love to be able to blend seeing patients in person, following up. I like to see patients in their home, to have them walk me around their house, to show me where they keep their medications, to kind of walk me through how to get into their house, and when they're in their home, what is their function like, and who's there to support them, what resources they lean on, what's on their sort of their mantles or on the kitchen table of their apartment. But that's not the only opinion. I have many colleagues who really feel they can't connect meaningfully with patients by video. They need to be in the room to read the room, so to speak, to be able to continue meaningful personal contact and the laying on of hands in many ways. And this, I think this variation of opinion spans in our practice across a wide variety of care providers, including clinicians, physicians, advanced practice providers, but also our nurses, our volunteers, our pharmacists, and so forth. And what we saw in this is really that depending on who was a critical mass at each of our sites really depended on how many people used telehealth. Once we got out of the initial portion of lockdown, everybody does virtual visits. And now when we emerged into a different area where we were figuring out what our new normal was going to look like. And in some of our sites, there's continues to be a wide divergence of opinion about how best to use telehealth. Is this really only for our COVID patients who are in the ICUs because we want to limit exposure? Is this really for patients who in follow-up can be seen after an initial outpatient consultative visit for specialty palliative care? Is this really best to use for our hospice teams to remote into skilled nursing facilities where they're providing care for patients and family members? We have a group that's working on the use of integrative medicine therapies and complementary therapies via telehealth care. Chaplains, is it really the best use of our, quote unquote, our licensed clinicians, as the important discussion that took place previous, to see patients in person, and others can use virtual care. And I'm sharing this just as to hear the different opinions that people have brought forth to the table as we've decided or have been discussing options for continuing to use telehealth moving forward. I think what we also see is people struggling with the best ways to use telehealth that is a combination of both the practical, how they think that telehealth can be utilized, but also the fear. So to give you an example, we recently were caring for a patient with advanced lung cancer. It was a very complicated family scenario. And frankly, the patient didn't want to come into the clinic to see her oncologist, to see the palliative care team who was helping with controlled substances to manage cancer-related pain. And one day when the patient called in noting some acute symptom changes, the initial reaction for some on our outpatient team was to essentially say, well, we can't do virtual care, you have to come to the emergency department, versus others who thought about telehealth as a way to actually triage that visit. What's needed here? Is this a discussion? Is this to be seen in person? How might we use this telehealth models to really inform our recommendations and our decision-making going forward? And the conversation after that from across our team members was quite varied and reflected, I think, the varying concerns about differences in regulatory responsibility and what that might mean for licensure. So I think as everyone, I imagine, is reflecting in their own practices, this will be a continued piece of our conversation. also share with our telehealth and kind of our perspective on telehealth really varied based on site. Again, I practice here in Rochester. We have 15 specialty palliative care physicians, over 20 advanced practice providers, and almost 20 nurses who work in our practice. So we're very fortunate to be richly resourced in that way. And I work with my colleagues who are a practice of 3. And so how each of these practices utilized telehealth was quite different. And we had some groups who used telehealth really only to provide resources to the emergency department to appropriately triage patients, and are continuing to operate within that modality. We had sites who continue to use telehealth as a way to really port into ICUs across a single site, and this ranges from both the kind of provider-centric models of physicians and advanced practice providers and nurses, and also volunteers, music therapy, and one of our social workers actually has been working on an intervention to continue to deliver guided imagery interventions for patients in the ICU suffering with significant dyspnea and anxiety. We also have seen some of our sites focus only on outpatient care models, really utilizing telehealth and video visits only in the outpatient setting, the complete converse of another site of ours that has different resources. Similar, we see that in some models, as was discussed in the really brilliantly in the last session, really how to address the potential equity of providers who may have other responsibilities for caregiving at home, and who are worried about losing out on PTO and salary. So how can they use telehealth to continue to work at home while they might be under quarantine, or a member of their family might be under quarantine? And so I think this really quite varied response across even a unified system using a unified telehealth platform and medical record is in large part a reflection of both the variation of our palliative care practices, and also the types of palliative care being delivered in these sites, and what each site is being asked to do by their local leadership. And I think where this leads in our own discussions amongst our team members in hospice and palliative care here at Mayo, both here in Rochester and in all of our sites to different degrees, is really how much the adoption of technology is an ability to augment and stretch our limited resources based on local needs, and then versus really a way to, in some senses, expose the gaps of what we can provide. And perhaps we can talk about, sort of telehealth as really a light bulb that shines on the areas in specialty palliative care and the types of care that we provide to patients with serious illness. The last piece I'll mention with this, and again, just thinking about the diversity of adoption of telehealth, is also when we think about utilizing within a single system telehealth across state lines and the ability to support practices. Early on in the pandemic, this was incredibly helpful as we were able to see virtual visits in any hospital within our system in different states. And what does that now mean as we move into potentially this next phase? And how does the type of care being delivered from one site to another run up against sort of local site culture, an understanding of the patient populations, the relationships that we certainly in our specialty know are so critical to developing with teams who are referring to us in specialty palliative care. And so I think these are questions that I certainly don't have answers to, but certainly have come up and been a robust portion of our discussion. The last piece I'll mention before turning it back over to Dr. Huskamp is I think thinking about telehealth as a broader portfolio of technological interventions that will continue to challenge us in palliative care. To give you an example, with greater availability via video have come greater requests for our involvement. If you can zoom into an ICU room upstairs, why can't you just zoom into the critical access hospital 2 hours away? And for a site that doesn't have outpatient palliative care, well, can't you just do it from your inpatient team? So I think those are questions that really have caused us to look very carefully at our practice models, and also with a keen eye towards the sustainability of our practice as we seek to maintain a sustainable practice for all of our clinical teams and volunteers. And with that, I'll hold off on any further comments and look forward to the discussion.
Oh, thank you so much. Our final speaker today is Pat Justice. Pat is the Executive Director of Rural Health on the Office of Community Health Systems and Health Systems Quality Assurance in the state of Washington's Department of Health. And she's going to talk about the experience in Washington delivering palliative care in rural communities via telehealth during the pandemic.
Thanks so much. I'm honored to be among the speakers today. It's been a really invigorating discussion so far. Can we go to the slides? I'm not seeing them. There we go. And go to the second slide, please. Next slide. So I just want to give you a little bit of context. I'm going to talk about our efforts to reduce rural disparities and inequities with palliative care in Washington. And we started work on this using telehealth prior to the pandemic. So I'll sort of describe what we were working on and then how the pandemic affected that work. But first, to give you a sense of Washington, our urban area I sometimes refer to as Pugetopolis, which is kind of a string of metro areas along Puget Sound. But as you can see, 96.4% of the state is rural. And we have some counties that are frontier, which is more than rural. And depending on the definition of rural that you use, actually that's kind of an arcane art. The population that's rural varies from 8.4% to nearly 21%, just depending on the definition used. Next slide, please. So our objectives in this initiative, when we began in late 2016, was to assist the rural health systems and their communities to integrate palliative care in multiple settings so that people with serious illness could be served in their community. The thought is that at a time of great stress, leaving the people you love and the place that you love is really tragic. We want to decrease transfers to urban tertiary services, and our principle was to move upstream to serve patients with serious illness earlier in their experience of illness, and like all palliative care programs, working on sustainable funding models. Next slide, please. So I will only talk about sort of the telehealth related pieces of the model in any detail, but we began with community engagement, which involved a community-based team that we helped them structure to bring together that worked on an asset and gap analysis and then an action plan that included both medical and non-medical supports for people with serious illness. We've brought a great deal of training and coaching around clinical skills and culture change. And then we began with telehealth case consults, which I'll talk about more, and then progressed to direct-to-patient clinical telemedicine. Eventually, where we want to be is rural centers of excellence in rural palliative care, so the project can begin to, or continue to spread into the future on its own. So next slide, please. So this real life is more complicated than I designed it on this slide. But essentially, we're trying to, for primary palliative care, we're trying to build the skills and services right in the rural community. And that's a lot of territory in terms of, with the right training and culture and leadership, they're hungry to do this. We had the hypothesis that if we use case consultation, that could deal with another layer up of complexity. And then the idea was that as the complexity went further, that they would consult with a tertiary expert team. And as I'll talk about with lessons learned, it didn't exactly play out that way. Next slide, please. So I'm going to go through these lessons. First, gaps in broadband and satellite coverage are well known, and they definitely contribute to rural disparities in access to telehealth and telemedicine. I've talked with people in urban areas and they couldn't quite believe that we have these really large areas of our state where there is not a signal. That's improved under the pandemic. We actually had our Department of Commerce bring up 300 hotspots, but that was kind of a drop in the bucket. Rural health teams are vigilant to see if urban experts will underestimate their knowledge and skills or condescend rural clinicians. And I want to say that urban bias is real. I very much appreciated the comments about having the people who are in the community structure and design the care that needs to be provided because they know their community best. When we started our telehealth case consults, I think our experts felt the burden to be expert, and they would, the group would present their case, and then there would be recommendations, and that sort of stopped there. And early on, we debriefed every session. We realized what we wanted was a dialogue. And we made a decision not to go with Project Echo because we didn't want to be restrained in any way by model fidelity, because we wanted the rural participants to shape it with us. So how we differ is that we do not do a didactic. We pull didactic points out of the case discussion. As it evolved, our telehealth experts, or pardon me, our palliative care experts, who a few come from rural backgrounds, they're doing a really fine job now of affirming the skills that they see, offering empathy for how difficult these cases can be, and giving the rural teams a lot of room to interact with them in a dialogue. We think this works way better than expert recommendations sort of delivered in a banking deposit kind of model. So these case consults really operate at two levels. It helps improve the clinical care for that particular patient, but it's also generalizable education, and we really emphasize that. For example, in a particular case, we may be looking for all the opportunities where someone can align intention with the patient and family, and how would you do that in this particular situation. One of the realizations that came very early is that these rural healthcare teams have been caring for very complex patients already, and they know a lot about how to do it, and they relish this assistance provided by the telehealth case consults. Their knowledge and concern for these patients is remarkable and never fails to touch us all during these sessions. Next slide, please. So pertinent to the comments from, I'm sorry, I'm blanking on the name, but the gentleman from Picori, sorry about that. We have to assist people with the technology, particularly when they're not in a place where there's a signal. So we've learned to support patients with hotspot tablets, and then team members go to the patient's home, and we really have begun to work with blended models where a clinician, say a nurse, will be in the home with the patient, and then the rest of the interdisciplinary team is virtual. And that seems to work a lot better than expecting a patient to hook up and do this independently. But as our team's confidence steadily grew, and this was largely because of communication skills training. We're fortunate to have Vital Talk originate in our own state, and there are many other kind of training models and experts in the state that have worked with that material. So we've heavily emphasized conversations around serious illness, and that has raised confidence. It's a regret of mine in our evaluation that we didn't use a confidence scale. It was a thought I had earlier, but I know just intrinsically that, and by report, that their confidence has really grown. And so when they came to direct clinical telemedicine, and we were just starting a pilot conversation about how to move to that next step when the pandemic hit. And so, like many others, it immediately went from talking about how to do it to doing it, and then refining as you go. They wanted to use direct clinical telemedicine to serve their own patients. They didn't feel like they needed to, go to the distant urban tertiary team. They felt confident enough that they would use that modality to reach their own, sometimes sizable geographic areas. I'll give you an example. We have one county that is larger than Delaware, Maryland, and Rhode Island combined. So being able to tolerate the windshield time to serve the different folks in that county is hard to do. There are 10 organizations in a team in that county, and they kind of work at like a zone defense in a sense, in that different clinicians are responsible for connecting to the patient in different parts of the county, and then they use telemedicine to bring in other team members. Next slide, please. So just a few other lessons. We've used both a nurse clinical coordinator and a technical coordinator, and we think these are keys for success. The clinical coordinator works with the various cohort teams to prepare them to present a case. She definitely helps them have the confidence, and refine how they are going to deliver the case. She helps them with selection, and she just does a lot of aiding them in developing into it. Just to back up a step, at the rural health team at the Department of Health, we were really grappling with how do we add value to telehealth in the rural areas. And it was a large topic. So we decided this particular project would be our window, and it really has been. It's given us a window to where their skills are, where their confidence are, what they know about using it, what are the supports in the organization. So all of that is sort of played out in this window of telehealth and palliative care. We think these consults also model interdisciplinary teamwork and what that looks like. We're very fortunate to have a medical director for the project who is probably the most egalitarian, team-based individual I've met in my career. So he models that beautifully along with all the other team members. We worked closely all along with our state organization, Washington State Hospice and Palliative Care Organization, and it's been interesting because our rural project has really instigated them to begin now to unwrap, along with the pandemic, how to deliver services in other areas using telemedicine. Next slide, please. So I think this is my last slide. And so COVID-19 and beyond, it really helped our pilot sites, and we have 13 communities right now with 2 cohorts, and it really helped them jump faster from planning to testing and implementation of direct clinical telemedicine palliative care visits, in addition to our telehealth case consults. We see that they're going to go forward with telemedicine deeply integrated in how they deliver things. It's stating the obvious to say that urban expertise is not often available to rural communities, and there are few palliative care clinicians that are going to be able to come to a rural community to practice. So having that expertise guide and train that local rural health team has really worked for us, and it will go forward. In terms of the public health emergency waivers for telehealth that matter to rural, it's being able to have the rural health clinics and FQHCs be either originating or distant sites, the relaxation of the Medicare location requirements, payment parity, and we are fortunate in our state to have a mirroring with a state law for voice only, which we also believe, particularly in those areas of low capability to have access in terms of broadband or satellite, that voice only is a great option. So with that, I'll turn it back. Thank you.
Thank you so much, Pat. I want to thank all 3 of our presenters. Actually, I thought those were excellent comments, and I'm really looking forward to the discussion. I want to make sure everyone who's participating in the webinar remembers to put their questions or comments into the Q&A section of the site, not the chat, but the Q&A section, and we'll go through them as they pop up. But I wanted to start with a question or 2 while we're waiting for folks to add their own questions. One is something that Pat just touched on at the very end there. And I wanted to talk a little bit about the experience with telephone or voice only visits for serious illness care and what their role should be going forward, how, thoughts on how they should be used, how they should be reimbursed in the future.
My point on that would be it's based on patient preference. Somewhat it's the logistics, but we have used that when the patient really says, that's how I want to do it. And our state has been, as I said, been fortunate to create some parity for that and make it allowable. I'm not aware of, the outcomes, whether it's as effective, but it is patient-centered when the patient prefers that modality.
I guess maybe I'll just offer just one comment on this. I had a patient visit recently where I logged in by video, and the entire time the camera was angled right above their head to a really funny looking picture on the wall. And so I spent much of the visit, even after bringing it in, they couldn't figure out how to get the camera to work. And so I spent the visit mostly looking at a picture of them from, about 40 years ago. And it was lovely to see it. But after, 15 minutes, the question remains, would this have been as effective a visit to see them to do that or to have it by phone? And to your point about reimbursements, I think that's it's a really important question, because certainly figuring out how we create a sustainable model for payment for this is going to be important for so many different types of sites. The piece I will that I will ask maybe of the group and just share, when we think about the effective models for team-based specialty level palliative care, and I'm using that phrase really to think about as a specialty trained palliative care group operating outside of, say someone who is an incredible palliative care trained clinician in an oncology practice or primary care practice, to think what we try to deploy in that setting is a team-based model with our interprofessional team. We can do that to some degree in person. It is much harder to figure out technologically how to do that by video. It's not hard to do that with a conference call. And I think the question from a research perspective to think through is, are those going to be equivalent? And how do we monitor that so that we can get the reimbursement right? I don't have a particular set of expertise other than just to raise that question.
I think it's a great question. One of the issues that is very relevant in this field is that, prior to COVID, audio-only visits just were not paid for. So this is kind of a new, territory for insurance companies, health plans, clinical teams, and patients in terms of trying to understand under what circumstances this works well. Most of our research, when we look at the equivalent studies with in-person, really are dealing with things like, video interactive, interventions with telehealth. And I think the work that's being done now, to my knowledge, is still pretty emergent. But I think it's really a priority for us to get to, because even though CMS, and you read the physician fee schedule, they kind of reluctantly agreed to move it forward another year. There's going to have to be some real strong evidence if there's going to be any hope, I think, of insurance companies in the long run allowing those options. And we know for very seriously ill patients and patients that really have technological challenges, audio only is an option that sometimes is preferred by them and they feel very comfortable with.
Terrific. I have a question from a participant. Are there any particular tools or websites that the panelists or programs use that can help older persons and others who are technologically challenged, like Senior Planet, the AARP Tech Hotline? And then they also commented, and audio only has been critical for people without connections. But any thoughts on the tools and websites?
I would offer that the folks who offer our technical coordination, and I didn't talk about them, Northwest Telehealth, have developed a toolkit around preparing patients that I think is not older adult specific, but has been made in a really patient-centered way. And I'm not sure how much of that they have on their site, so I can check into that. And if I have a good link, I'll send it.
Oh, terrific, thank you.
Yeah, I know that there's been, oh, go ahead, Jacob.
Please, after you, Steve.
I was just gonna say, I know that, for example, in pediatric care, where there's been issues about, trying to get parents comfortable with certain types of telehealth applications, particularly in an area where patients or parents have been very resistant to bring, really desire to bring their children in person for care in pediatric settings. That during COVID, a number of the national children's hospitals have put together some websites to try to help facilitate that for parents that have children that they were very nervous about, exposing in an institutional setting. But I don't have the websites up to my mind.
Jacob, did you want to add?
I was going to say I don't have a good sense of tools other than to acknowledge that the the technology piece is just, Pat's comment about access in Washington. My grandparents are one of those people outside of Puget Soundopolis. I'm gonna have to remember that. I probably got it wrong. But, they're out on the Olympic Peninsula, and that is a real continues to be a real broadband access issue. And I think what they found just as personal experience is that the telephonic continues to be really meaningful as a modality, just to augment that when they can't get the right broadband signal. And I see Rodney's hand up, and so I'll let him take on that next question. It looks like, or sorry, Dr. Huskamp, I'm jumping out of my lane.
No, I was just going to do the same thing. So happy to see if Rodney wanted to chime in on this one.
Yeah, more or less a comment. I think that while the disruptive innovation of telehealth has obviously transformed our menu of options, and as Pat said, increased access in many areas, I think the verdict's still out on quality. The verdict's still out on the telephone visits. I know that we have now only begun to really pay attention to visual acuity and hearing and technology when we first assess somebody, because we're still requiring initial visits be face-to-face. And I know Phil Rogers, I think, had a question, but I am only cautiously optimistic / pessimistic that telephone-only reimbursement will continue. I think there's a tremendous amount of concern about overutilization and abuse and lack of documentation, and how long this can go on, and not being able to see in a patient's environment. There are a lot of concerns, obviously, about opioid management and the way that that's carried out. So I think we have a technology that's going to add to the menu and have many good aspects, but it's not a one size. It's not a savior for access, and it could potentially even worsen disparities, as we all know, because some folks don't want to use their technology. We have a lot of folks, obviously, in Alabama that only have, paid card, telephones. They don't have broadband. And if they begin to feel like they're going to be marginalized because they can't do telehealth, then we have to be careful.
Just to add one additional question about reimbursement, I think a couple of our panelists mentioned parity reimbursement for in-person versus televisits, and at least one person commenting that it was important to ensuring access to telehealth. Some people have argued that the costs of delivering services via telehealth are lower than the infrastructure or costs that are needed to deliver in-person care, and then make the argument that as a result, telehealth should be reimbursed at a lower rate. And I'm curious your responses to that.
I'm not clear on the evidence, and I'll apologize for that, but in experience, what our cohort members are telling us, that it takes an equal amount of time and coordination to get those visits to work. I mean, I guess you don't have to pay for electricity for the keep the lights on and the heat and the building costs, but in terms of people time, they're still quite intensive to get it coordinated on the front end and then to close up that visit. At least that's been my experience.
I guess maybe I would just use that as a nice linkage to Rodney's last point, is that if I guess my shared worry is that because telehealth for some can be done easier, that it is done less robustly. So to Steve's, when he was commenting on some of Dr. Temmel and Dr. Jackson and Dr. Jacobson out of Mass General, kind of looking at what are those key components that are done within video visits that lead to sort of potentially higher quality outcomes, let alone in in-person visits. Again, how do we then make sure that those are still occurring within these technologies? So I guess that would be my only concern, is that we think of it as, because it may be. I would agree with Pat. I think we struggle with getting with sort of the same kind of time intensity and people intensity doing video in many ways. But I think I worry about sort of the difference in reimbursement and what that actually means for the types of care being delivered.
Yeah, I think the one thing I'm a little concerned about is, trying to put everything in one bucket of, audio versus something else, because particularly when you think of individuals with low health literacy, low numeracy, there is a lot of work to prepare them for these kinds of visits to do it effectively, at least in some of the research that we're seeing at this point. How that actually plays out in terms of a relative value unit, I'm not sure, but I'm very concerned that if we take a very mean comparison, we're going to really miss an opportunity for the kind of human support that's very necessary for them to set up, to use the technology, to facilitate communication, virtually. Those are real costs that involve other people. And I just want to make sure we're comparing apples to apples when we think about the different challenges that these populations have.
That's a great point. Another question from a participant: have any of your respective organizations encountered challenges with providers experiencing barriers to engaging via telehealth, either due to infrastructure limitations or limited comfort or tech savviness? So barriers are on the provider side as opposed to the patient side, which we've mostly been focusing on.
I'm doing my palliative care, wait several seconds before speaking, but I love this question because it's the resounding answer is yes. And the more nuanced answer is that the challenges are all over. We have, most of our clinicians have picked up the technology pretty quickly. Where it got down to is really how, just without the familiar components of sitting in the office, that, in some senses, and I'll be maybe a little bit controversial, some of the hierarchy that exists in being the doctor who comes into the office, there is a that throws, I think can throw people, and has, I've had colleagues mention that to me. It's just they were surprised by that, and so I think it's thrown people for a wide variety of reasons. I think similarly, for many of our clinicians who were very we're used to being able to grab a colleague down the hall, or to see, bring in our social worker or our chaplain to really provide that robust level of care. Doing that is different. I mean, it is doable. It is doable, and we've really begun to build out strategically some of our care models to allow for the person first experiencing the patient on video, whoever that might be, to be able to to bring in the colleagues that they need to into those visits to augment, whether, again, including to Pat's point earlier, the patient's own primary provider. How can that be done? So and I think that there still are those barriers still exist, the comfort level, and I think for anybody who continues to go at a Zoom and the person who's talking continues to talk with their mic muted, we've done how many Zoom calls now, and that still happens. I think we still are struggling with the right cadence within these visits. So I think the short answer is yes, and the solutions are, I think, continuing to engineer the systems that support high quality visits, with the ways that we can.
I was just going to mention as well that I think clinicians are right to have to take some caution here. I mean, we don't really have good standards in place that have been, promulgated by specialist societies and a lot of these kinds of modalities, and to give clinicians clear guidance on, what seems to work and what doesn't work, even though there is an evidence-based developing. And I think for a number of clinicians, there were, this was just kind of seen as something that was going to have to be a stopgap until we could get, outside of the pandemic. And the other thing we don't have is we don't have quality measures. We don't really have ways of measuring accountability for good telehealth interactions, like we do for clinical care in the inpatient side, in the in-person side. And I think that's another area that would be helpful to develop, to give clinicians, more confidence that, that the value that many people are anticipating for these kinds of modalities really can be measured and can be accounted, and that there's opportunity for clinicians to learn how to do better as they do more.
So I build on that by talking about the part that's probably not easy to measure, but we really found that the person who's supporting the technology, how they do that matters a great deal. If they're doing that with a sense of, real warmth, and it's okay not to know how to do this, and assisting people in a way that doesn't make them feel on the spot or ashamed, that goes a long way to getting reluctant people to come back to it. And so I think the personal qualities of the technology assistance really matter. And I don't know how we'll measure that, but it's definitely some of the secret sauce to get people engaged.
It seems like when we think about telehealth, people often think of it as an all or nothing. So for example, a clinical trial will often look at a fully virtual model versus a fully in-person model. And I think there may be much more of a role for sort of a hybrid model going forward. And just wanted to get your thoughts. I think your comments touched on this a bit, but sort of what are some of the different ways you could see these two modalities being combined effectively? And what might hybrid care look like?
We have one example in the Providence Health System in the northeast corner of our state. So this is one of our cohort teams who's gaining confidence, and they have a board-certified palliative care physician and a very experienced PhD in social work, behavioral health, palliative care expert. Those two individuals are telemedicine into the visit, and then the local team is with the patient. And that blended model is really working well for all concerned from everything we can tell.
I guess I would comment, kind of in very similar fashion. The more we can partner with, as a palliative care clinician, to Pat's point, partner with the clinicians who are primarily managing that patient, whether that is, again, a community health worker in the home or a primary care clinician, or, what I do a lot in my practice is visits with oncologists. What we've just started to do is really to do some virtual partnering with the patient, their oncologist locally, and then a palliative care specialist to do some of those visits together. I think that's been, very meaningful for us as clinicians, and we'll see if that ends up being something that we can measure some improved quality outcomes on. I think this is where the mixture of these types of visits are something that we have to build around. It also presents a challenge. And again, I mentioned this very briefly earlier, that when we can do more of the things flexible, the question is, where does one say no? Where do the guardrails from a staffing model that, I think our colleagues in the previous session talked about, when someone at the end of their shift, the end of their day, that they're actually going home and they're not just always perpetually on call for virtual types of care, that presents a challenge. And I think where we have just started to nibble on this a little bit is what does it look like? What does an on-call model look like? What responsibilities exist there, both telephonic, virtual, in the hospital? What does it mean what does scheduling visits mean, whether they're partnered, whether they're on a template, for example, and also how that will change within the setting, within a hospice setting in a more rural community like we have in the west of our region, versus within an academic setting. So I think that's going to take resources from the data analytics, from the quality improvement, from the sort of business engineering perspective to help us figure that piece out a bit better, and not on a how do we optimize revenue and reimbursement, but how do we optimize sort of that people, the investment in our person capacity and our person capital to do this work, for a longer period of time.
Yeah, and I just say that particularly dealing with serious illness care, I think almost all our protocols at least have a minimum of a first visit, where before anything engages with telehealth moving forward. So at a minimum, almost all these models are hybrid, at least from my experience when we're thinking of serious illness care. But the one thing that we're seeing in the data is that, the sustainability of these performance over time really starts diminishing. And the notion that we probably need to begin thinking about what is the periodicity of having, reconnection, particularly with clinical teams in a virtual, in-person basis, is something that I think still requires further study. What's that real dose effect that can allow a good hybrid model, and particularly in frontier communities and others where, simply driving, 90 minutes to get to a 15-minute clinician checkup is just not practical.
Yeah. I wanted to just follow up on something you said, Jacob, about the sense that I'm getting then is that it's almost as if within your organization, the demand for your services has expanded in ways apart from just what's going on with the pandemic, but more and more folks are seeing palliative care as an option that they can bring in for taking care of their patients or in their regular work. And how is that affecting how your organization views your group and the commitment they're thinking going forward to resources that should be dedicated to care?
Yeah, thank you for that question. It's a great question. I think, and there's probably two pieces. The first is, yes, there is a sense that, okay, well, what type of differential investment do we need to move, particularly as we start to see the blurring of lines between inpatient and outpatient care. So the commitment to grow, what are transitional care models? What does it mean to do, quote unquote, hospital at home or acute care at home? And how will palliative care play a role there? I also think there's a fear, and there's a fear on my end, certainly, but also, gosh, there's all these areas that could potentially benefit from palliative care services. We don't have enough of you. We can't hire enough. We don't want to, that's a potentially enormous investment. And I think in some senses that is a fear because of the workforce challenges and the sustainability that we all face. I think there are some potentially exciting opportunities. And Pat, I'd love to hear your perspective on some of the kind of, again, the primary specialty types of palliative care models and how this may help. And I guess I would also say that even that notion that there's sort of specialty palliative care and basic palliative care, this binary sort of model that it's, you're either a specialist or you're not, I think is appropriately being challenged by technological interventions like telehealth. And so, for example, when we are looking, we're using, in addition to sort of to figure out where to expand, we're using artificial intelligence and machine learning to sort of combine with patient-reported outcome data to better figure out which patients could benefit most from a specialist. And then where are the gaps that we need to deliver different systems strategically within the organization to be filled by other members of the care team, and using that care team very, very broadly. And not that they're doing generalist and we're doing specialty. We're doing different parts of the care model for a patient with advanced serious illness. And so, again, instead of necessarily needing to see me, do they need to see a mental health counselor, a community health worker, a physiatrist, occupational therapist? And how do we use technology to do that, of which telehealth then might be one of the next steps for intervention. So I think that's where there's a lot of potential opportunity. Now, there's a ton of risk and concern associated with AI that we won't get into necessarily right now, but I think that's both the fear and the opportunity that we're looking at.
Yeah, I would say for the rural health workforce, helping them skill up to be able to attend to the needs of this population is critical. But with that, knowing where their limits are, which they face all the time in terms of figuring out who to keep and who to send. So they've got to know their limits, but there's a lot they can do, and they are so pleased. I know I'm making a generalization, but it really is, I've drank the Kool-Aid. There's really almost an elation for them of feeling a new confidence in having these conversations. And then with the pandemic, they became the experts in their organizations that were not afraid to have these conversations around goals of care and, hold a family meeting and that sort of thing. So for people in these geographically isolated places, and I hope your folks were okay on the peninsula with the deluge of rain we just had and wind, it's got to be part of the picture that we're helping this whole workforce. And I think the fourth consensus standards had a lovely statement towards the beginning about anybody who has contact with somebody with a serious illness needs a certain primary set of skills. And that means really across care teams. And I appreciate your comment about there's not a clean demarcation that makes any sense between primary and specialty. I think it is, it's much more subtle and connected than that.
Terrific. I'm curious if you had to pick one or two sort of policies or regulations or sort of reimbursement issues that you think get in the way the most of delivering serious illness care via telehealth, what you might pick. What's really creating barriers for you? Or in the case of Steve, not personally, but is he from the work across projects, what he may be hearing about?
Well, I'll go with broadband expansion. You know, the companies are reluctant to go into low population density areas because it doesn't pay. But I think this might be an area where we want to regulate them to do their part to contribute to closing those gaps in coverage. Because it really is, rural disparities are being, I want to compliment the CDC. For the very first time, they had a rural carve out in funding for a COVID equity grant. So the recognition of rural disparities have grown during the pandemic, as well as the racial and ethnic, and broadband capacity is the thing that can decrease those disparities to be able to reach people.
Anything else?
I think, you know, for us, one of the things that continues to be a pain point as we're trying to reach broader patient populations, as we're trying to reach beyond regions, is sort of the differences in state licensures for so many of our team members, and how, you know, how do we ensure that we can get the team members that are needed to deliver high quality palliative care where they're going to potentially be regulated because of whether that's because of state licensure rules, whether that's nursing, pharmacy, physician, advanced practice providers. I think those are areas, especially with a limited workforce within palliative care, again, just speaking in that space, that, again, get no argument from me that we don't want to be thoughtful about how we regulate sort of who's providing care and the standards of care that we're providing, and how do we, you know, again, reduce some of the barriers that that allow greater access, you know, again, outside of population dense areas, outside of large academic centers. I mean, I think particularly if I just, you know, looking at outpatient palliative care and where that can be provided, just still significant limitations that, you know, again, one wonders what we might build with some reduced barriers, some greater broadband access, as Pat notes, and kind of continued thoughtful attention to making sure we're providing high quality care. I guess that'd be one thing that's on my mind recently.
Yeah, the other thing I'd add to all those excellent suggestions, which are on my list, particularly I'm very, very cognizant of what Pat said, since I've been spending the last year and a half in a very rural area, learning a lot about the challenges that that exist in living in rural areas. But the other thing is I still want to go back to this reimbursement issue, because particularly for patients that have real challenges, you know, low literacy, they need extra human support, no matter if it's audio, video, you know, you name the technology. And I'm just very concerned that we're going to lose an opportunity, particularly if we find value with these, that we will be back to where we were before pre-pandemic, where there wasn't a recognition of the kinds of resources that are needed to make sure these patients can participate. And if we don't do that, I'm very concerned that these disparities and the principles of health equity are going to continue to plague us in our health system.
Well, I really want to thank Steve and Jacob and Pat for a really interesting discussion. And I want to turn things back over now to our co-chairs, Bren and Susan.
Yes, thank you, Hayden. We would like to express our gratitude to you, our speakers and participants for bringing this workshop to life today. Although healthcare in the world did turn upside down 20 months ago, COVID can be a force that helps transform our health system for the better. Our robust dialogue has emphasized the imperative to integrate equity into our core structures, prioritize workforce and patient safety, and identify the best models and policies for optimal care delivery. In the spirit of this season, I am also reminded of how much I treasure and appreciate each of my fellow healthcare workers. I hope that we will use these learnings to improve patient care and our work climate. Bryn, would you like to close us out?
Thanks for those closing remarks, Susan. And before we leave, I just want to note for everybody that a video of today's webinar recording will be archived online at the National Academy's Serious Illness Roundtable website. And I would also like to encourage people, if you found this conversation interesting and useful today, to register for our third and final webinar in this series. That webinar will focus on the importance of science and public health communication and on policy strategies to move serious illness care forward. That webinar will be on Tuesday, November 30th, so please join us. And thank you everyone for taking part in this conversation today.